டென்ஷன் ஆயிடுது.
Madam, good evening, madam.
Good evening, sir.
Good evening, madam. Yes, sir. Sir, one sir, madam.
Moderator sir வந்துட்டாரு.
Oh, fine, madam. Oh.
Sir, good evening.
செந்தில் சார் உங்களுக்கு தான் சொல்றாரு.
Madam, good evening, sir. Good evening, sir. Sir, yes, sir. So we'll start around 4 p.m., sir.
Right.
Yes, sir. Okay.
அவதாரணி மேடம்.
சார்.
வணக்கம் டாக்டர் தாமோதரன்.
சார் வணக்கம் வணக்கம். உங்க திருமுகத்தை காட்ட மாட்டேங்கிறீங்களே.
வரேன் மேடம். கோயம்புத்தூர்ல வச்சு உங்களை பார்ப்பேன்.
நான் பார்க்கலீங்க சார். ஹலோ சொல்லவே இல்லை நீங்க.
அடுத்த மாசம்.
ஓ ட்ராக் வரீங்க.
ஆமா வரேன்.
சூப்பர் சூப்பர்.
ஓகே சார், நல்லா இருக்காங்களா?
நல்லா இருக்காருங்க சார்.
கேட்டதா சொல்லுங்க.
நீங்க நல்லா இருக்கீங்களாங்க சார்?
நல்லா இருக்கேன். ஓகே.
ரொம்ப நாளைக்கு அப்புறம் உங்க குரலை கேட்கறேன்.
சரி, எலெக்ஷன் அப்ப கேட்டோம் இல்லையா?
அஷ்ரப் சார் குட் ஈவினிங்.
குட் ஈவினிங்மா. குட் ஈவினிங்.
Sir, good evening, sir.
Good evening.
Sir, good evening, sir.
Dr. Panneerselvam, sir.
பன்னீர் நேத்து வந்திருப்பாரு என் பிரதர்.
சொல்லலாம்னு நினைச்சேன், சொல்லிட்டு கேட்டீங்க.
நான் சொல்லியிருந்தேன் அவன்கிட்ட. எல்லாம் நீங்களும் லைன்ஸ்ல இருக்கீங்களோ?
ஆமா அவர் சாருடைய பழைய போட்டோ காமிச்ச உடனே சந்தோஷம் ஆயிட்டாரு.
ஆமா சொன்னான். He's one year younger to me. He's looking after the Gold House, T Nagar as well as Anna Nagar.
Oh.
And Tamara. Thank you, Tambi.
Thank you, sir.
Thank you. எங்க சிக்னல் கிடைக்காம போயிருமான?
Good evening, sir. இப்படி வைக்கணுமா? இதுதான் கரெக்டா?
Good evening, Ashraf sir.
Good evening, Abdullah. Good evening.
Sir, good evening, sir.
Abdullah is
Good
always
evening,
on
Sindel.
the, always
Yes,
on
sir.
the
Good evening,
move.
sir.
Anand,
Sir,
good evening.
Sir, good evening.
Anand.
Ashraf sir, good evening, sir.
Good evening.
Yes, sir.
Good evening.
Good evening, sir.
Ashraf sir and Abul Hasan sir, Gauri Shankar sir also joined. Can you start the meeting now?
Yes, sir. We will start,
It's
sir.
4
Yes,
o'clock.
sir. Time is 4 o'clock.
Yes, sir.
Exactly. We will start. Yes.
Yes, sir. A very good afternoon to all the delegates. I welcome you all for the second day of the annual state conference of CGP. Today is the second day where we are going to discuss about diabetes and hypertension. I would like to request our state office bearer, Dr. Suresh Kumar sir from Palni, to give the IMA and physician prayer. Dr. Suresh Kumar sir.
Yes, sir.
Yeah, please, sir.
Good evening to all. Good evening to all. Physician prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Gives singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of rare privilege that is mine. Take from my heart all guilt and holiness, that with the simple faith of a child I rely on thee. I am a prayer. May everybody be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask for the ground, nor I wish to be in heaven or reborn. I only want to alleviate the sufferings of those people who are burning in fire of sorrow. Thank you, sir.
Thank you, Dr. Suresh Kumar, sir. Now, I would request our Chairman of Studies, Dr. Sendil Kumar, to give his welcome address for the gathering. Dr. Sendil Kumar, sir.
Thank you, sir. So I welcome all our delegates for day 2 of this CGP conference. And I welcome our immediate past president, Dr. Abul Hasan sir, our past president, Ashraf sir, and our finance secretary, Dr. Gauri Shankar sir, and our speakers for the day, Dr. Muruganathan sir, Dr. Bavadarni madam, Dr. Sundaram sir, and moderator for the session, Dr. Paneer Selvam sir, for this wonderful session. So we have this online conference for next 3 days. I request all our members to kindly log in between 4 to 7, and Saturday alone it will be 5 to 9. So I request all our members to make use of this wonderful session. And all the links are already available in the YouTube channel, IMA TNSB. So kindly you can follow all the channels. All the sessions are immediately uploaded and it is ready for your views. Thank you, sir. Over to you.
Thank you, Dr. Sendil, sir, for a brief welcome address. Now, I would request our immediate past president, Dr. Abul Hasan, sir, to give his words of felicitation and his presidential address. Sir, Abul, sir.
Thank you, Anand, Sindel, all the delegates, past president Dr. Ashraf, Dr. Muruganathan, and other faculties, and my dear friends. I am very happy to learn that yesterday this program was started with a big bang, with the maximum number of attendees, and it is going on for another 3 days, and it will be ending with a physical meeting. I am very, very confident that this particular webinar series would help our doctors with lots of tips and messages for their practice. Of course, learning is a continuous process in medicine. Our branch schemes, wings like CGP and IMS are doing wonderful work in this direction. And particularly our Tamil Nadu CGP team is very, very strong and has lots of strength to carry on further and further and take IMA CGP to greater heights. I wish this webinar series where all the purpose solved, all the purposes are met, and people joining the webinar will be immensely benefited. Thank you very much, and all the best to you, Dr. Anand.
Thank you, sir. Thank you for your
Thank you,
kind
sir.
words of felicitation, sir. Now I would request our past president and the national vice president and the chairman of the standing committee, Dr. Ashraf, sir, to give his words of felicitation to the gathering. Dr. Ashraf, sir.
Anand, thank
Yes,
you,
sir.
Dr. Suresh and Dr. We had our Sendil. I think this is one of the best, one of the blessing in disguise in Corona is the webinars. Yeah, we were not aware of these Zoom meetings at all earlier. The Zoom meeting has come as a boon for all the people to learn. They can sitting in their own places, in the clinic, they can study, learn, update their knowledge. So that is a very big thing which we have learned in Zoom. Here, to go to a small history, we have a lot of delegates who are speakers here. I welcome all of them and thank them for taking their giving their time, spare time to participate in this program. We have diabetologists, cardiologists, all of them spending the time. We have here. Now, what I'm trying to tell you is, when the IMA was started, it was mainly focusing on studies. And there were only general practitioners. Very rarely, we never had specialists. MD, MS, now we have super specialty, subspecialties. So IMA was functioning, all the national IMA was functioning in Delhi. It was at that time they started two divisions. One was AMS, Academy of Medical Specialties, and College of General Practitioners. And that was also functioning from Delhi. It was only later, about 30, 40 years back, that they took a decision to shift CGPC, decentralized. They started one at CGP headquarters at Chennai. That is becoming a real effective IHC because all our members are now very, very active in CG. I still remember 92 to 94, what the post which is Anand is holding, I was holding the faculty secretary of Tamil Nadu. Now we have a national secretary, Dr. Amuda is here, CGP secretary, we have Anand, we have all our Sendil, all of them are taking active interest. The webinar, please concentrate on topics which are useful to general practitioners. For a small example, diabetic foot, how to treat a diabetic foot, what should a general practitioner do, what he should not do, when should he refer. And they should all have a working knowledge of ECG. Then they can immediately diagnose a cardiac event and refer to a place if there is angioplasty or thrombolysis. With these two words, I thank all of you for giving me this opportunity. I wish all the delegates who are participating here will benefit from this. So the expertise of all the speakers here. Thank you very much. God bless.
Thank you, sir, for your words of felicitation. We would like
Thank
to
you, sir.
live up to your expectations, sir. Thank you very much, sir. Now we request our State Treasurer, Finance Secretary, Dr. Gauri Shankar, sir, to give his words of felicitation. Dr. Gauri Shankar, sir.
Thank you, Anand, sir. Most respected, our immediate past president, Dr. Abulasan, sir, our past president, Dr. Ashraf, sir, and Dr. Murunathan, sir, Senthil, sir, Anand, sir, and from Palani, Suresh Kumar, sir, our speakers, Bhavadharni, madam, and Sundaram, sir. So, good evening to all. So, there is a stiff competition between CGP and AMS. So, last week, AMS people have done a wonderful job there in Kadalur, and now CGP is going on well. So I heard that there were more than 2,000 registration, 2,500 registrations nearly, and now here also now attendance is keep on going. That I think when I logged in, it was around 270. Now it is around to 688. So very fabulous job is done by our office bearers, Dr. Anand sir and Senthil sir. So it's very useful for all
Gauri Shankar, sir.
members. Yes.
Yeah. Now only you're audible. Yeah, you are now out of line. Yes.
So,
Gauri, one day over Gauri. Just stop the vehicle for a short time.
Stop sir. Okay. Sir, shall I start from the beginning, sir, or?
No, sir. It's
no
audible,
problem.
sir.
You can continue.
Continue. Okay. So now the participants are now it's 7 total actually. So it's a very fabulous job done by our office bearers with the support of all our seniors. So we're having a felicitation program on Saturday. So I think all the programs are going on very nicely, and the selection of speakers is also very good. So we're having our Dr. Murunathan's speech is there. So particularly there are a lot of followers for his speech also. So it's a good job done by our Senthil sir and Anand sir for selecting the speakers also. So thank you very much for the opportunity, and best wishes for the success of the program. So thank you, everyone.
Thank you, Dr.
Thank you,
Gauri
Gauri,
Shankar,
sir. Yes, sir.
Thank you, sir. Thank you, sir.
present, Dr.
Oh.
Rohit, get a small, if possible, make a small booklet. The academy la pandra mari, you can take from Dr. Panniselvam, Dr. Sundaram, Dr. Bavardhan, we can have a small booklet. You can send it to the delegates. This is what I am planning for my academic committee also. Just
Yes,
keep
sir.
this
Okay.
in mind. Any assistance
Okay,
I'll
sir.
give you.
Okay, sir. We'll try to
Yes.
implement it,
Okay.
sir.
Okay, sir.
Okay,
We'll do
sir.
it, sir.
Thank you.
We'll do
Thank
it,
you.
sir.
Yes, sir.
Do it, sir.
So now before going into the topic per se, I would like to say a few words regarding the IMA CGP. Like CGP, as all you know, most of the members of IMA know about the CGP, and they have been regular attendees of our all webinars or the direct conferences which we conduct. And particularly, if there are in this conference till today afternoon, there are around 2,617 registrations for this year's conference, which has surpassed last year's of 2,000. Nearly there were 2,100 last year and more than 500 today itself in this year. So I'd like to thank all the delegates and the doctors for supporting our Tamil Nadu branch of IMA CGP in large numbers. So that we are also very much overwhelmed by your response, and we try to improve on the topics being given to the delegates who are attending the CGP conferences. So at this outset, I would like to request all the members to know that there is a CME on particularly neurology on coming Friday, and we are going to inaugurate the new fellowship course for IMA CGP in neurology in that conference. So this is a new course which has been exclusively designed to cater to the needs of CGP members, people who are doing general practice, particularly right from ENT to neurology in a very short nutshell. So I would like to take this opportunity to people who are interested to attend that CME fully and know about the course which we will be giving then. And if interested, kindly join the course and make use of the good faculty which we have procured. And this is a new course which is being inaugurated from this year alone. So with this short speech, I would like now request our Panniselvam sir to take over the proceedings and to conduct the today's CME, sir.
Sir, unmute. Pandit sir, unmute.
Pannirom, madam.
Thank you.
Yes.
Thank you very
Thank
much.
you, sir.
And
Thank
also,
you,
I would like
Ashraf
to
sir, and
inform that registrations are open till July 12th, Saturday. So all our members who are attending can register till July 12th, sir. Yes, sir. Kindly proceed, sir. Yes.
Yes, sir. Thank you, sir.
so thank you very much for your College of General Practitioners and Ashraf sir words forward. So it was very nice. I am happy. I am also a member of IMA from 82. I was a member at Viluppuram, then subsequently shifted to Kodambakam. So after COVID, such meetings are definitely helping our colleagues by sitting in their clinic or on the house, or we are also sitting from our place. We could able to communicate. In that way, I wholeheartedly congratulate the entire team, and especially my colleague Dr. Bavdharani is actively involved in all IMA activities. Not only she is getting involved in IMA activities, she started actively involved in diabetes activity also. Since almost for 3 years, she will be our Research Society for the Study of Diabetes of India, Tamil Nadu chapter secretary also. So our aim is through IMA, we want to reach all the practitioners. We want to inform all the practitioners about normal levels of blood sugar and HbA1c. What do you mean by uncontrolled diabetes? If it is uncontrolled, for example, fasting more than 150, postprandial more than 200, A1C more than 7 for minimum 3 months, maximum 6 months or 1 year, what to do further? At the end, from your end, if you could be able to control. Otherwise, kindly refer the patient to nearby either physician or diabetes center, because 80% of our patients are being diagnosed, not getting controlled, simply ignorant, or wandering the clinics or hospitals. This should not happen. So this is myself, I am chairman-elect, and Bavdharani is secretary. We are aiming to reach all the practitioners all over state to pass on this message, to identify uncontrolled state and put the patient. Patients are as usual ignorant. There is no doubt about it. It is up to our responsibility to put them in the good path, that is metabolic path. See to that they are running in the good metabolic path. At least we can reduce the quantum of complications. In this aspect, Dr. Bavdharani is, I think, she is the first speaker, isn't so?
Yes, sir.
Bavdharani,
Yes,
right.
sir.
So she is going to talk on primordial prevention of diabetes. So prevention of diabetes per se is much possible. It is being proved from 1999 by Donking study, China study. Subsequently, for 10 years, more than 20 studies have proved diabetes is preventable. Unfortunately, knowing that we are not in a position to prevent diabetes, rather, we allow the diabetes to grow fast, especially in younger people, and they enter into complications, they struggle and suffer with the complications. Even though the literacy rate, per capita income improved, and service also, medical service also improved. Dr. Sundaram used to tell 10 or 15 years before, number of diabetologists are not sufficient. Now, all over country, every practitioner is diabetologist. But despite sensitizing our colleagues, many of them are not under control. Simply, they are wandering the clinics. They enter into complications. So we have to prevent diabetes. If not, keep diabetes well under control. Before prevention, there is a condition called primordial prevention. We can prevent diabetes in utero itself. How we are going to prevent diabetes in utero? That is the topic for Dr. Bhadarani today. I think she is well versed with this topic. And she is also associated, myself also associated with Professor Sheshaya. Sheshaya and Dr. Sam G.P. Moses only throw this idea from 1982, almost now 45 years over. So they have sown the seed. Now the seed is getting grown well. But again and again, we are not in a position to prevent diabetes. The importance of primordial prevention. What do you mean by primordial prevention? How to prevent primordially? Those things Dr. Bhadarani is going to highlight. She is very well known to IMA. I need not highlight about her. And she is qualified diabetologist, finished her diploma diabetology in MMC during 1991. And she has rich experience in the field of diabetes and rich experience in the pregnancy and diabetes. She had been conferred by diabetes pregnancy study group or the Lifetime Achievement Award. As well as at Nagpur also, she was given Lifetime Achievement Award. She has received so many awards in diabetes pregnancy. Over to Dr. Bhadarani.
Thank you, sir. Thank you, the chairperson, for giving me this wonderful opportunity. And also, I thank the entire IMA leaders for conducting such a wonderful program for all the general practitioners, especially Dr. Sendil and Dr. Anand Chokalingam for regularly conducting all these meets and also conducting courses for the general practitioners. Pranams to my godfather, that is Professor Dr. Seshia, and pronounced to my teacher who is also with me today, Dr. Sundaram. And with all these words, I am going to my topic that you all know that diabetes is affecting every family. It has become a door-to-door problem. We are fighting for AIDS, we are fighting for other conditions, cancer, everything. But if you see, diabetes is the only thing, as far as I know, diabetes, hypertension, and cardiac problems, all these lifestyle disorders, rather than calling non-communicable diseases, these are nothing but lifestyle disorders which have started because of our wrong, faulty lifestyle. And this is ruling the community and the whole world now. We need to take some steps. Of course, now we are saying that how to detect diabetes, how to create awareness, and how to prevent obesity. And most of the people are in the state of metabolic syndrome. You can see, of course, our BMI, as far as India is concerned, BMI is less, but still all are having the visceral obesity, which is the cause for all non-communicable diseases. So how to overcome this? Though we are fighting to prevent diabetes, we do not know where it starts. So today I'm going to talk about the condition where it starts, where its root starts, and how to grab from its roots. You know, obesity, it's very high. Those days when we are studying in the school, only 1 or 2 will be obese and we'll be pointing that obese. But nowadays, we are finding it very difficult to see on ordinary, not the thinner one, ordinary children, especially in the females, the obesity is increasing like anything. And in females, after conception, we do come across more of congenital anomalies. And hypertension is also equally more, if not more than diabetes in the community, but goes unrecognized and not given much importance. And we do come across more of big babies, and cardiac problems has increased, and it is an equivalent. Having diabetes itself is like having cardiac problems, and we have neonatal hypoglycemia and IUGR, small babies, and hydramnias during pregnancy, other problems, preterm, difficult labor, so many other problems during pregnancy. For all this, if you see what is the cause, it is the pregnancy. During pregnancy, the cause is hyperinsulinemia, of course. The maternal hyperglycemia and fetal hyperinsulinemia is the kingpins of pregnancy metabolism. We'll see what is all this. See, if you take my mentor, Professor Dr. Seshia, he did a study in 2007 among all the pregnant women. He didn't screen in the third trimester. Of course, he screened all the pregnant women attending the antenatal clinic in the maternity hospital, Chennai, and he has found that gestational diabetes manifests in all trimesters. In contrast to what we think that it occurs only in the later trimester. He found it was 16% in the first and 22% in the second trimester, and of course more in the third. If you are not going to screen in the first and second, you are going to miss almost 50%. That is 40% of GDM in our practice. So what he did, he repeated the same in after 10 years. That is in 2016. What he has found, it has doubled. In the first trimester, which was 16%, has become 32%. And in the second trimester, which was 22%, has become 42%. And again, the third trimester, it has come down because of our fast changing in the lifestyle. We are getting more and more lifestyle disorder during pregnancy, which is manifested in the form of gestational diabetes. The same thing, when we attended ADA in 1980, they said it is only type 1 diabetes which passes through pregnancy. Before the invention of insulin, what they said, pregnancy is contraindicated in diabetes. So they are not allowed to become pregnant if they happen to be diabetes. The same thing after 40 years in 2020 in Norbert Finkel lecture, they have said in ADA, American Diabetes Association, like what our mentor said, it is not the type 1 alone, also type 2 and also diabetes detected for the first time during pregnancy gets manifested along with the true GDM. The GDM which occurs in pregnancy, that is gestational diabetes, is because of the insulin resistance which aggravates the diabetogenic stress which happens in all females because of the hormones secreted during pregnancy like estrogen, progesterone, and human placental lactogen, which are all diabetogenic. But our body, what it does, it produces more insulin during pregnancy and overcomes the diabetogenic stress if our body is fit without any insulin resistance previously. So what happens? Every female has all these secretions of hormones and do have this diabetogenic stress, but all women are not developing. That is, who are fit to become pregnancy, that is overall not having all these insulin resistance, they do overcome this diabetogenic stress and they do not develop diabetes. That is the diabetes during pregnancy. And so the uncontrolled, that is those who are not following the proper lifestyle or the one who have insulin resistance already and they only develop GDM. And this is the cause for all the future problems. So female gender is the key for diabetes prevention, said Liz Kingo. How this is, we need to prove. David Barker again said that body's susceptibility to all lifestyle diseases is programmed intrauterine. Yeah, our old Chanakyan said the baby's future are all decided in the womb. The womb is more important than the home. So what is this intrauterine programming? The gestational programming is a process whereby a stimuli, whatever it can be, maternal fuels or any stress that occurs at the critical or sensitive period of fetal development permanently changes the structure, physiology, and metabolism, which predispose the individual to diseases in adult life. All these are decided in utero because of the mother's intrauterine environment. So this is the fetal origin of adult diseases said by David Barker. Keeping in this mind, instead of screening all the high-risk cases, that is those who had already BOH or big babies or who are obese, who have a strong family history, now it has been made mandatory that all pregnant women without any risk also has to be screened in the very first visit, not in the late trimester, that is 24 to 28 weeks. They have to be screened in the first visit, first trimester. Previously, it was a cumbersome GTT. They have to come in the fasting. We need to give glucose load and see the fasting 1 hour, 2 hour. Some before it was up to 3 hours, but now it has been made easy by our mentor that irrespective of fasting, whether the lady comes in fasting or non-fasting states, she has to be given 75 grams of glucose and the blood sugar has to be tested at 2 hours. So what do you know from this? That all pregnant women in the very first visit with a single step procedure, they have to be screened. And if the value after 2 hours is 140 or more, she is diagnosed as GDM. In spite of screening all these in the very first visit or in the first trimester, we were able to prevent the problems like eclampsia, preterm, big baby, all this. But when the baby is born, we are not able to prevent the childhood obesity and the baby getting early impaired glucose tolerance, that is pre-diabetes. Now you all know we are seeing diabetes even in young children, school-going children. It's present even at the age of 6, and we do find a lot of IGT, pre-diabetes in school children, that is metabolic syndrome and future diabetes and all other non-communicable diseases like our hypertension, cardiac problems, all continues to increase. In spite of we doing all this, it's continuing to increase. So our father of GDM, Professor Dr. Seshia, after scratching his head for a long time, has come out with the concept of primordial prevention of diabetes. We'll see what it is. When you take the pathophysiology of GDM, it happens because of the hyperinsulinemia in the mother. This affects the placental growth, angiogenesis, and lipid metabolism, and this is transmitted to the fetus also. It's the problem in the mother initially because of the increased blood sugar in the mother. There is hyperinsulinemia, which affects the placental growth, angiogenesis and lipid metabolism and transmitted to the fetus. This response of the placenta to the hyperinsulinemia is initially from the mother's side. Then later, this hyperinsulinemic effect is taken over by the cytotrophoblast of the fetus by fetal handling of the mother's sugar. How this happens? By 11th week, the fetus starts responding to the mother's blood sugar. Initially, increased maternal blood sugar causes increased insulin. This hyperinsulinemia is the one which affects the placenta by increasing its growth, angiogenesis, and also lipid deposits. This is transmitted via the placenta from the mother to the fetus. And not only this, the excess blood sugar via group 4 and group 1 enters the fetal side, and the fetus starts responding to the mother's blood sugar by 11th week, that is by secreting insulin. The fetal pancreas starts secreting insulin by 11th week, and this hyperinsulinemia in turn affects the placenta and also the fetus by increasing the cardiac hypertrophy and causing cardiovascular problems later in life, by stimulating the beta cell and leading to exhaustion of beta cells and type 2 diabetes later in life. and fetal fat deposition causing obesity early, that is in the childhood. And with increased fetal growth, the baby is big and difficult to deliver. And with impaired hypothalamic development, it has effect on the feeding behavior. What happens? You can see the children born to GDM mothers with hypoinsulinemia who are having more appetite and eating more and developing all these problems. Thus, increased fat deposit in the placenta leads to lipotoxicity, oxidative stress, and decreased angiogenesis and inflammation. And David Metzer, he has again seen that those with increased fetal insulin, if you measure the fetal insulin level, if it is high, they become obese very early by 6 years, and they do develop, 1/3 of them, 33% of them develop pre-diabetes at 12 years of age. In contrast, if you see those children with normal fetal insulin, they do not become obese. And in contrast, only 1/10 of them develop pre-diabetes by 12 years. It is because of their improper lifestyle. And this insulin resistance, which is already present in the female, is the one which increases the atherogenic lipid profile, inflammatory markers, hypertension, and endothelial dysfunction, leading to increased risk for cardiovascular disease later in life. Thus, GDM, that is the female, is the mother of all non-communicable diseases, what we are seeing as told by our mentor, Professor Dr. Seshia. This is nothing, the legacy effect of what happened in the intrauterine life is manifested later in life as non-communicable diseases. But what we are doing is we do organizing a lot of camp to detect diabetes early and to treat them. This doesn't mean that we are preventing diabetes. What we need is to prevent diabetes from its roots, primordial prevention of diabetes. That is, the disease should not develop at all. Is it possible? What we are concerned is prediction of GDM. What we can do is we can say whether the female is going to develop GDM or not. If she is prone to GDM, then we have to stop it by giving metformin. So when to test to predict this GDM? NIH has said it is at 11th week, that is at 10th week. Why this 10th week? Why it has told 10th week we have to screen? Because if you take the embryology of the beta cell development, that each islet cell starts that is developing by 4 weeks and starts the fetal islet deposits can be seen by 7 to 8 weeks, and it starts responding to the blood sugar of the mother by 11th week. So we have to be very cautious. This should not happen. The fetal pancreas, once it starts secreting, the process is irreversible. It continues to secrete throughout pregnancy, and also after it is born in its life, this hyperinsulinemia continues, and this is the cause for all the problems later in life. See, for example, I'll say a lady comes to us at 10th week, her blood sugar is 126. We are asking her to review after 2 weeks. The blood sugar has come down from 126 to 112. How does this come down without any intervention? Of course, as I said, at 11th week, the fetal pancreas has started functioning by secreting insulin. This has controlled the mother's blood sugar. So the postprandial blood sugar has come down. Now the blood sugar will not go up because of the fetal handling of the mother's blood sugar. Initially, the mother has hyperinsulinemia because of the increased sugar in her. Once the fetus starts secreting insulin and controlling, her hyperinsulinemia comes down. The fetal takes over the consequences of hyperinsulinemia. Whenever the mother's blood sugar crosses 110, we have to take immediate action to bring down this blood sugar less than 110 before 10th week. Because 11th week, the fetal pancreas starts functioning. Before the 10th week, it has to be brought down less than 110 so that the fetal pancreas is not functioning. See, here you can see whenever the blood sugar, blood glucose and other nutrients, if it is excess, it crosses the placenta and stimulates insulin secretion. The hyperinsulinemia is not good. It causes adiposity. We know it develops macrosomia. That's all. But remember, the mother's blood sugar is this much, but because of increased secretion from the fetus, it looks normal or low. Actual blood sugar is high. Because of the control from the fetus, it looks low. So you may miss the diagnosis of GDM also. See, here instead of the fetal secretion being low this much, it has increased this much because of the increased blood sugar in the mother. So the blood sugar of the mother has brought down by fetal insulin secretion, that is hyperinsulinemia in the fetus. This fetal handling of insulin is likely present before GDM diagnosis, not at routine 24 to 28 weeks where we see for GDM screening. The fetal glucose steal phenomena could mask the maternal hyperglycemia. This hyperinsulinemia once started, it steals glucose from the mother. So the mother's blood sugar always looks normal after the secretion of insulin from the fetus. So why this 110? If you take the adult renal threshold, it is 180. The same way, the fetal renal threshold is 110. It is not 180. The fetal renal threshold is 110. So whenever the mother's blood sugar crosses 110, the fetus is going to respond to it by secreting insulin. Since the fetal renal threshold is 110, and whenever the blood sugar crosses 110, it senses it as hyperglycemia and secretes insulin to bring down the blood sugar. The fetal secretion starts at almost 11th week, but the problem is once the fetal insulin secretion starts, it will not stop. It is irreversible. It continues throughout gestation and also postnatally throughout life. You can even test yourself. That is, nowadays we are seeing so many adolescent girls having this hyperinsulinemia. It means they are already insulin resistant with the metabolic syndrome features. They are only facing pregnancy. So nowadays it's a day where we should control the hyperinsulinemia is the girls before they become pregnant, and they should be fit to conceive. Otherwise we cannot stop all this. But it has crossed and nobody is ready to control that diet. Initially what happens, this hyperinsulinemia in the fetus, it steals glucose from the mother as long as it is inside the mother. But after delivery, the glucose supply is cut off from the mother. What happens? It goes in for recurrent hypoglycemia. Many of the logicians, they have asked, the mother was not having GDM at all or any problem, but still the baby we had polyhydramnias, the baby has become big, or the baby goes for recurrent hypos. What is the cause they used to ask? Remember, this is the cause, the hyperinsulinemia in the fetus, which has occurred much, much earlier, that is at the 11th week, causes all these problems. This hyperinsulinemia is the creator of all non-communicable diseases, not only our diabetes. Hence, to prevent diabetes and all other non-communicable diseases, we should not let this fetal hyperinsulinemia to happen by controlling the mother's blood sugar before the starting of fetal insulin secretion. And again, another study done by AOGs, it has shown that if the mother has hyperinsulinemia, they are also prone to give birth to infertile sons. Nowadays, we are having so many infertility centers. This again can lead to infertile sons. And we need to predict the GDM at 10th week by doing only one postprandial blood sugar. That is, at 10th week, 110 shows that the lady is going to develop GDM in future. So, like preparing for exam, you need to work well ahead. That is, at 8th week itself, you have to see the blood sugar so that you can bring down the blood sugar less than 110 at 10th week. So, see a postprandial blood sugar at 8th week of pregnancy. If it is 110 to 190, you have to put them on metformin. And along with lifestyle modification, that is medical nutrition therapy. And this has to be continued till delivery. Otherwise, if the blood sugar, whenever the blood sugar crosses, the fetus will respond to the increased blood sugar. So when you see between 110 to 119, you should put the lady on metformin 500 half BD till delivery. You can see the response later. If necessary, you can increase the dose of metformin. Your aim is to bring down the blood sugar less than 110 so that the fetal pancreas is not functioning. This should be your aim. This will prevent the development of GDM in the mother and all its consequences. The framing of the fetal cells around 11th week accounts for all the persistence of fetal hyperinsulinemia throughout pregnancy. So, metformin, you may doubt whether it can be used or not. It has been proved by many studies. It is the only anti-diabetic which has been shown to be safe from conception to birth. This has been again very useful in preventing preeclampsia. Again, preeclampsia and other things are also due to insulin resistance and hyperinsulinemia. Once you detect this 110 early at 8th week and put them on metformin, the lady will not only be prevented from developing GDM, but also she will not develop preeclampsia or polyhydramnios or any complication during pregnancy. It will be a smooth cakewalk. So remember, this is very important. Prevention of GDM is possible by bringing down the blood sugar less than 110 at 10th week. For this, you have to start acting at 8th week. And then only you can bring down less than 110 at 10th week. If it is 110 or more, the fetal beta cells will secrete insulin and it will become irreversible process. 110 to 119, 120 is GDM. Postprandial 120 is already GDM. So 110 to 119, you can put them on metformin. So coming to the stages in the classification of hyperglycemia in pregnancy with glucose, if the blood sugar is 200 or more, it is diabetes in pregnancy as well as outside pregnancy. If the blood sugar is 140 to 199, it is GDM in pregnancy, whereas outside pregnancy, this is a pre-diabetic stage called impaired glucose tolerance. Why we are bothered about this impaired glucose tolerance? This is the one which causes all the macrovascular problems like hypertension, stroke, cardiovascular problems, and peripheral vascular disorders. Whereas GDM, the legacy effect starts, and this is the one for all cardiovascular problems and diabetes, hypertension in future. If the blood sugar with glucose touches or increases 120 itself, should be very cautious. Like impaired glucose tolerance outside pregnancy, this is the gestational glucose intolerance. And now what we are seeing for the prevention of GDM is 2-hour postprandial. It is not with glucose, it is after food, 2-hour postprandial. If it is 110 to 119, that is early gestational glucose intolerance, which has to be treated with metformin, and all these problems are prevented in future life. 2-hour postprandial 110 at 10th weeks predicts the development of all. So you have to start your action at 8th week. If you see this 110, you should put them on metformin 500 half BD. See the response after a week. If she's not responding, you can increase the metformin and bring the blood sugar less than 110 so that she is not developing GDM. So GDM is the window of opportunity for prevention of cardiometabolic disorders. So to achieve a diabetes-free generation, I can say non-communicable disease-free generation, you have to focus on the fetus for the future. Thank you. Any doubts? I'll be
Hello.
very happy if you have
Thank you,
any.
thank you, Dr. Bhavarani.
Yes, sir.
You have very well highlighted about the importance of detecting diabetes, controlling diabetes. Not only that, you had gone into deep of primordial prevention, and the importance of numbers. Less than 110 is very important during pregnancy. More than 110 to 120, early gestational diabetes and gestational glucose intolerance, then IGT or GDM, then more than 200 GDM. So you have very well highlighted. So we request all the practitioners, at least you make a note of these numbers, because sometimes some of them are getting confused. Which number is correct for which disorder. So the ultimate aim is, whenever you come across pregnant lady, if it is early pregnancy, either you yourself can do postprandial blood sugar only, simple. You can do it with the meter or by lab. If it is less than 110, then you repeat the test after a few weeks, or after 10th week or 12th week, then 16th week, then 32nd week. See to that throughout the pregnancy less than 110. If it is more than 110, as she pointed out, diet advice plus metformin. So by which we are going to prevent gestational diabetes per se. Once you prevent gestational diabetes per se, you are going to prevent diabetes in future generation, and you are going to prevent diabetes in the mother also. Because now most of the GDM mothers, 3 to 4 years after delivery, they become frank type 2 diabetes. If they are not under control for another 3 to 4 years, they develop all complications, as she told, all your vascular complications. So to avoid all those things, better to focus on fetus. Early pregnancy screening is very important. She has very well highlighted. Whatever the doubt you have, you can ask her. We are here, Dr. Sundaram also has joined, and we are here to clarify all your doubts for some time before we go for next topic.
So Dr. Muruganathan vandutara?
I think he has not joined.
No, I have joined. My Pandit, I have joined.
Sir, Rukkar.
Oh, sir. Right, sir.
Good evening, sir.
Thank you, sir.
Good evening.
Good evening, sir.
Good evening. Video on. I was just listening to your talk, Bhavdarni.
Sir,
It
we
was
are
good,
waiting
sir.
for
Thank you,
your
sir.
talk, sir.
Yeah, it was
Sir,
good.
give your comment on the talk, sir.
Yeah, you are there as a chairperson and moderator, so I thought you'll do better. And of course, after the after both of our talks over, we'll have more discussion. And I think there are about 9,000 people around.
Yes, sir. 900 people, sir. Only 1,000 people, sir. 1,000 people.
Yes. So what do you want now? Can we go ahead with our program, or?
Yes, sir. We can go ahead, because I think they can ask some questions, but I do not know whether they are in the chat box or not. Or you finish your talk, sir. We can have the discussion at the end, sir.
No, just see, is there any question in the chat box?
Wait, sir. Chat is about 99 chats are there.
All the numbers only they would have given.
I think how to wean the GDM patient from metformin after delivery. What is the target blood sugar to achieve after delivery? Like Bhadarni, how to wean the GDM patient from metformin after delivery? What is the target blood sugar to achieve after delivery?
Sir, what is the? Sir,
how
please
to wean
repeat.
GDM? How to wean the GDM patient from metformin after delivery?
Sir, after delivery, because the placental diabetogenic stress has stopped, you can very well stop metformin, and you should also see the blood sugar. Because nowadays, as you said, we need not wait for 2, 3, 4. Pre-GDM is very common. That is, diabetes occurring during pregnancy has become very common. As I showed in my thing, there is a paradigm shift. What we saw previously was only type 1 passing through pregnancy, but we do have diabetes detected during pregnancy. So you carefully see after pregnant delivery, what is the blood sugar level. Then you decide whether they have to be treated throughout, continue the treatment, or you can stop. It depends on the blood sugar.
The light went.
And now they have done a study and shown that we need not wait till 4 to 6 weeks. At the 3rd day of this delivery, in the placental, once the placental response is over, at that time itself, you can decide whether she is going to develop anything. If she shows any IGT or any form of abnormality,
In biscuit
can
one
very
madam.
well continue with metformin.
Right. Good. So
Okay.
her message is after delivery, invariably, once the placental hormone is disappearing, the blood sugar will become normal. You can withdraw metformin. But after withdrawing metformin, better to monitor the patient. Better to monitor the patient. See to that her PP blood sugar is less than 140. If it is persistently 140 on annual checkup, especially after 3 days, then after 6 weeks, then annually. But all blood sugar must be less than 140. If it is crossing 140 means she is entering into IGT. Then we have to intensify the prevention control and see to that blood sugar is well under control throughout her life. So immediately after delivery, you can withdraw for most of the patient. But this category requires close monitoring and we have to prevent diabetes in future for her. That is the message. Then another question, ma'am, what is the
Postpartum
difference?
care is equally important like antenatal
Yes.
care.
Yeah.
Hmm.
Of course, antenatal care, we have to frequently check up. Here we can check up minimum 6 months to maximum 1 year after 6th week of screening.
So
Ma'am, what
somebody
is the
has
difference?
asked what is the difference between GDM and diabetes during pregnancy. That is, you can do the HbA1c. If you are in doubt whether it is GDM or diabetes has occurred during pregnancy, you can do the HbA1c in C. If it is from 5.3 to 6, it is GDM. More than 6, it is pre-diabetes. That is, diabetes has started during pregnancy in that lady. Mostly after delivery also, they'll continue to be diabetic. You have to closely watch, as Dr. Paneerselvam said.
Okay.
Sir, another question is, what is the difference between the 75-gram glucose and 100-gram glucose, OGTT?
Now it has been
70.
made universal. You need not worry about 100 grams, 125. Previously, we were giving according to the weight and we were doing the 3-step procedure, very cumbersome, all that. Now it is very easy, irrespective of pregnancy, pregnant, non-pregnant, except for children, all it is 75 grams of glucose. And especially in pregnancy, because we face so many problems in centers like rural centers where the ladies cannot come again and again. They are daily wages. They are always accompanied by another person, 2 wages gone. And again, they come in the early morning after taking care of all the household work and also taking care of the members of the family and domestic animals. They cannot fast for a long time. And also the elders in the family believe that they do not fast for a long time. And they do not have the frequent bus transport facilities also to come again and again. Considering all this, and this is not the only test which has to be done during
sir.
pregnancy.
We can start now.
Yes, sir.
Yeah. The madam, she finished that.
Yeah.
So
Okay.
they have come out with a single test, easy procedure.
I think only one message, Bhavarni and Paneer. During a pregnancy, especially when the person has got GDM or diabetic, ask them to take care of their sleep pattern, sleep hygiene, because many times the recent studies show the sleep disturbance is very common in the first trimester, second trimester, and third trimester. And these things always alter the blood sugar. So please advise the patient to have the good sleep hygiene pattern so that the blood sugar is under control, apart from all the other things what you said. That just for completion's sake, I want to add this point. So
For
thank
any
you.
diabetic, sir. For any diabetic.
Yeah, no, any diabetic, but especially pregnancy, because there are so many hormonal changes during sleep, and especially the first trimester, second trimester, and third trimester. There are a lot of studies now. They've shown how sleep can affect the blood sugar, especially in GDM person.
Yes,
so this is another point, which I think everyone should, inform the patients and patient attendants. Make sure that lady is taken care of and given a good consoled comfort sleep. Okay, with this, I think I will be very happy to move on. If Sendil, can I go ahead?
Sir, moderator is
sir,
Dr.
please, sir, please, sir.
Paneerselvam.
Oh, Paneerselvam,
Yes,
okay.
sir.
Okay,
Sir,
okay, sorry.
I am the moderator, sir. So you are very well known to all of us. You don't require any formal introduction, etc. And the topic also very important topic for all of us. You are very fond of hypertension topic. You used to talk in many platforms. So you are going to share what is new in hypertension or what role as a general practitioner they have to do. So I think you will do your justice for your topic, sir. You are known to that. Over to you, sir.
Paneerselvam, I'm also fond of diabetes. No,
Yes,
not
sir.
only hypertension, it's not a diabetes also. So no.
You are an
No, many
all-rounder,
plots.
sir. Sagalakala
Yes, sir.
Vallavan.
Okay.
Yes, sir.
Thank you so much. Now can I start sharing?
Yes, sir. Yes, sir. Here a share option.
So exactly now 1K has come. So I think now good evening, dear brothers and sisters. Also,
Sir,
my
slideshow பண்ணிருங்க sir.
yeah, we have given the slideshow only. Slideshow. Pointer method. Okay. Slideshow. Okay. Is it okay now?
Yes,
Yeah.
sir.
Okay.
Audible seen.
After listening to best and good lectures from Selvam and Baudarni about diabetes, we'll move on to hypertension. You know, friends, hypertension is much more prevalent. The morbidity and the mortality is 3 times more than the diabetes. You know, you will be surprised to know there are 30 crores of people with hypertension in India. Not only that, out of 30 crores, only 12 to 14% are under control. The main reason for not under control is only, main 2 things. One is the clinician inertia and then poor adherence by the patients. And also inaccurate measurement. See, blood sugar measurement now very, very easy now. So many methods have come. Simpler than the blood sugar measurement. Blood pressure measurement is very, very simple. But only thing we have to do we have to do accurate blood pressure measurement. And every physician, everybody should also train the paramedicals and the patients how to measure accurately. Just like home blood sugar monitoring, we should popularize home blood pressure monitoring also. And one of the recent, all the guidelines recommend for managing hypertension, you will have to give a combination therapy. In those days, when we were students, we are starting with one drug and then escalate the other same drug. Then we'll change over to second drug or then we'll add drugs. But now, even in the first phase, whenever somebody comes as a hypertensive, you have to start low dose combination therapy. See, that's what every international guidelines and Indian guidelines recommend. With this background, now I'll move on to my topic, management of hypertension, combination therapy. My roadmap to the topic is why to combine and where to combine, how to combine, where is the confusion in combination, and from the confusion to clarity in combination, how not to combine. Certain drugs you should not combine. Then summary and takeaways. So this is my roadmap. So let me start with why to combine. You see, when you give a monotherapy for hypertension, for example, let us say telmisartan 40 milligram. The changes in the systolic blood pressure is only, let us say, 6.9. And if you increase T40 into T80, that is telmisartan 80, it is gone to 12.2. Whereas the same telmisartan 40, if you combine with the hydrochloride of 12.5, the change in blood pressure is more than around 19. Same way, valsartan 80, it's only 8.2. When you increase valsartan 160, it becomes 12.6, not even double the reduction. Whereas if you combine 12.5 hydrochloride, it becomes 16.8. So you can see the difference between 12.2 to 18.8 and 12.6 to 16.8 when you combine a drug with the monotherapy. Why? What is the rationale for initial combination therapy? It is due to counter-regulatory.
Sir, your slides are not changing, sir.
It's changing.
Sir, slides are not seen, sir.
Not seen.
Slides are seen. Slides are very well seen.
I think
Very well seen, huh? But here,
Panneerselvam, you wear your spectacles. You wear your spectacles, Panneerselvam, please.
Voice heard, slides seen. Slides very well seen, voice heard.
Okay, thank you, Baudarni. Thank you.
right. And now it is seen.
Okay. So I think the sound is echoing.
So somebody is not muted. All of you, please mute.
Okay, now it's okay. See, the rationale for initial combination because of the counter-regulatory mechanism. To offset the body's counter-regulatory mechanism to a particular agent. I'll give you the example, what is meant by counter-regulatory. When you use diuretics alone, it can result in volume depletion and that can activate RAS system. And to lesser extent, the sympathetic nervous system activity. The use of agents that block these systems, such as ACE inhibitor or beta blocker, counteract the body's response to diuretics and are complementary to diuretic action to low BP. I'll give you another example. See, everybody knows when you give calcium channel blocker amlodipine, there is a pedal edema. When you combine calcium channel blocker with ARB, the pedal edema is relieved. Or if you combine with diuretic, the side effect of amlodipine is relieved. I'll give you the one by one example. This is called complementary or compensatory. When you give ACE or ARB with CCB, normally CCB produces edema, there'll be less edema or no edema. When you combine calcium channel blocker with ACE or ARB, there is less cough. See, normally some people develop cough when you give ACE inhibitor. Whereas when you combine with calcium channel blocker, the cough is less. Same way, you give diuretics with ACE or ARB. Normally, diuretics can cause hypokalemia. ACE inhibitors can cause hyperkalemia. So both are balanced now. So less potassium change when you give diuretics and ACE and ARB. Beta blocker and calcium channel blocker. Beta blocker can produce bradycardia. Calcium channel blocker produces tachycardia. So the combination, there will be less bradycardia. When you give beta blocker and diuretics, less sympathetic activation. Same way, diuretics with ACE, less RAS activation, and diuretics with ACE or ARB, more efficacy. So you give alone, for some people, ACE inhibitor alone, in blacks, it may not work. But if you combine with diuretics, the efficacy is more. So that is why complementary or compensatory mechanisms due to counter-regulatory actions, the combination is very, very crucial. Now I'll go to the where to combine. I talked to you about why to combine. Now I talk about where to combine. This is the Indian Hypertension Control Initiative, Indian Hypertension Control Guidelines, API guidelines, where we see we have got the target of 130/85 and the target of 130/80, the threshold 130/85. And again, for below 65 years, no high risk, you give 130/80. And between 65 to 80, the threshold is 140/90. The target is 130 to 140. And then above 80 years, it is 140 to 150. So BP should not be less than 120/70. So this is the threshold and the target. Most often, we require combination to achieve the target. So that's why we combine drugs. Now, the choice of drugs, you would have heard A, B, C, D. A for ACE inhibitor, Rampril, Perindopril. Another A is ARB, Telmisartan, Valsartan, Losartan. And then now new thing we are adding ARNI also. For the B, bisoprolol, metoprolol, carvedilol, and nebivolol. These are the beta blockers. For the C, calcium channel blocker, amlodipine and benidapine. For D is diuretic, chlorthalidone and indapamide. We don't use alpha blocker as the first line drug in the ABCD column. Now, this is the previous approach. You would have in 2018 and all that, the guideline says the step 1 below 55 years and above 55 years, step 1 is A or B, the monotherapy. Or in above 55, C or D, calcium channel blocker or diuretic. In step 2, if there is no control with the step 1, they add A or B plus C or D. That is step 2. In step 3, they were giving A or B plus C and D, triple drug combination. In 4, resistant hypertension, they add aldosterone antagonist or spironolactone. So this is what previously they were talking. A word about resistant hypertension. Resistant hypertension is a blood pressure when you give all the three drugs, optimal dose, one of the three drugs is diuretic. Even after that, if the blood pressure is not under control, it is called resistant hypertension. And if you give 4 drugs and if you control the resistant hypertension, it is called control resistant hypertension. If you give 5 drugs and there is no control, it is called refractory hypertension. So resistant hypertension, 3 drugs, optimal dose, diuretics. Diuretic, one of them is diuretic. If the 4 drugs can control, it is called control resistant hypertension. If you cannot control blood pressure even after 5 drugs, it is called refractory hypertension. Now, this is the decision algorithm to start combination therapy in hypertensive patient. In a frail older patients above 80 years, or patients with only mild hypertension or grade 1 hypertension, low or moderate risk, particularly if the systolic BP is less than 150, you can start with monotherapy. Whereas patients with high normal BP and high CV risk, if you is there, you can consider single agent. If there is no, if it is not there, then you start with dual combination. This is the recommendation by the American Heart Association 2021. Now, this is what I said. Frail older patients, they will be given only monotherapy. Now coming to the how to combine. We have talked about why to combine, where to combine. Now how to combine. This is very, very important. This is what you'll have to understand. Ladies and gentlemen, brothers and sisters, please understand only this slide. If you can understand this slide, my whole talk is over. The interplay of various factors affecting cardiac output and peripheral resistance. You see, after all, what is blood pressure? Blood pressure is equal to cardiac output into total peripheral resistance. So blood pressure is cardiac output into total peripheral resistance. Now, let me tell you one by one. How do you get cardiac output? Cardiac output, because of the excess sodium intake, genetic factors, the fluid volume is more, and because of that, there is preload. And because of the stress, high sympathetic activity, venous constriction, the contractility is more. So this contractility and preload are the main principles or pathogenesis for increased cardiac output. So whenever there is an increased preload or whenever there is an increased cardiac contractility, the cardiac output is increased. So when you increase the cardiac output, I told you BP is cardiac output into total peripheral resistance, the blood pressure increases. Now I come to the other pathway. This is one pathway how blood pressure can be increased. Increased preload, increased contractility. When renin-angiotensin excess there, again there is a vasoconstriction, and genetic and metabolic factors also can produce vasoconstriction, and this can also lead to vascular hypertrophy. So these two things can increase total peripheral resistance. So I told you blood pressure is due to cardiac output into total peripheral resistance. Any of this mechanism, first mechanism can increase cardiac output. Any of this second mechanism can increase the total peripheral resistance. And when you multiply, the blood pressure goes away. That is why persistent hypertension can develop only in response to increase in cardiac output or raise in peripheral vascular resistance. So hope you have understood this slide. If you can understand this slide, my future slides will be very easy. So you understand this mechanism, you understand this mechanism also. Now I'll go one by one now. Now you can see for fluid volume, we give diuretic. Why? It will reduce the volume, so preload is reduced. When there is a contractility more and sympathetic activity is more, we give beta blocker. So that reduces the cardiac output. So diuretics and the beta blocker can act by reducing cardiac output. Calcium channel blocker, alpha blockers, and angiotensin inhibitors can reduce total peripheral resistance and thereby decreasing blood pressure. So these are the mechanisms how diuretics, beta blocker, and then calcium blocker and angiotensin inhibitors reduce the blood pressure. These two reduce the total peripheral resistance. These two groups reduces the cardiac output. Having understood this, we'll go to one by one. Now, the principles of combination. it can be different mechanism. What do you mean by different mechanism? One, it reduces cardiac output. The other drug reduces peripheral resistance. So there are two mechanisms. As I told you, you can see this one mechanism and this is the second mechanism. When you combine diuretic with calcium channel blocker, one is reducing fluid volume, other is reducing the peripheral resistance. So if you see different mechanisms, you can use beta blocker and the calcium channel blocker, or same mechanisms but different pathway. For example, the calcium channel blocker and the angiotensin inhibitors are combined. It reduces total peripheral resistance, but this is different and this is different. So same mechanism, different pathway. So same mechanism, different pathway, where cardiac output or peripheral resistance can be reduced by either by beta blocker diuretic or peripheral resistance by A and C, angiotensin A inhibitor, IRB or calcium channel blocker. Same mechanism, same pathway. What is it? It is the either it reduces cardiac output or peripheral resistance. Most important is the diuretics. Now we will go to the next point. Where is the combination? So we have already told you why to combine, where to combine, how to combine, and where is the confusion now? The confusion is here. In 2020, the International Hypertension Guidelines said the step one is you start with dual low dose combination of A or C, A plus C. The first time itself, see, they've already classified in ISH optimal and essential. In the optimal, the step one is dual low dose combination of A plus C. Step two, instead of low dose, you make it a full dose. In step three, you A, C, and D. Now, step four, in resistant hypertension, you add triple drug combination plus spironolactone. So this is the ISH guidelines. So use whatever drugs are available with as many of the ideal characteristics as possible. Use free combinations if SPCs are not available. Single pill combination are not available or unaffordable. You can give combination like this. Use thiazide diuretics if thiazide-like diuretics are not available. Use alternative to DHP, dihydropyridine calcium channel blocker, if these are not available or not tolerated. Then you can use non-dihydropyridine calcium channel blocker like diltiazem or verapamil. So this is the ISH guidelines, International Association of Hypertension Guidelines in 2020. Now the practical algorithm for pharmacological blood pressure lowering. Now they say initial monotherapy. I already told you when there is an elevated BP category, that is 130 to 89, or the frail individuals, anybody above 85 years, you start monotherapy. If not, you start a low dose double combination. It can be ACE or ARB plus CCB or diuretic. And then after a follow-up, if 1 to 3 months, if not improved, then you give, instead of increasing the 2 dose, you increase low dose triple drug combination. And if there is no improvement, the blood pressure is not under control after follow-up, then you add the maximum dose of triple drug combination. At any time, beta blocker should be given if there are any compelling indication like angina or ischemic heart disease or heart failure. So apart from these, whenever somebody has got a comorbidity or a associated cardiac problem, you will have to add beta blocker. And then in full year, if there is no control, you kindly refer the patient to a hypertension specialist or test for adherence, look for secondary hypertension, add spironolactone. So this is the practical algorithm given by the ESC guidelines in 2024, ESC guidelines, European Society of Cardiology guidelines. So this is what I said, double drug, low dose, double drug combination, then triple drug combination, maximum dose, and then give a spironolactone or refer to the specialist for altering the combinations. Now, this is what our Association of Physicians of India guidelines, the recent guidelines says, at any stage of hypertension above 140/90, low dose dual combination, A, B, C, D, monotherapy, anything monotherapy, either ACE inhibitor or calcium channel blocker as a single drug. And then if it is not controlled, you give low dose triple therapy, A, B, C, D, low dose. Then maximally tolerated dose A, B, C, D. That is the step 3. And step 4, that is called resistant hypertension, where we can add spironolactone, mineralocorticoid antagonist, spironolactone. If side effects, then use eplerenone. If there is a side effect of spironolactone, like gynecomastia, if the potassium is too much, then you can try eplerenone. And then add 5th drug, alpha blocker, centrally acting agent, or direct vasodilator like minoxidil. Even then, if there is not improved, it may be a case of refractory hypertension, where you can try renal denervation therapy. In those days, they were saying renal denervation is not very effective. Now, with the advanced technology, renal denervation is an option in a patient where there is a refractory hypertension. Now, the confusion. See, I have given you all the combination. Understand the combination. We use whether the same combination in all condition, which combination in which condition, what is the dose of initial combination, how to escalate them. If it is not controlled, how do you escalate them? How to select the third and fourth. Suppose you give only 2 drugs. How do you select the third or the fourth drug? Which combination is not used in which condition? Which combination is not preferred at all? So this is the confusion for many of us. So now I will clarify your confusion. From confusion, I will take you to the clarity. Having understood the basic mechanism and pathogenesis of hypertension, and what is the method, one method and second method, the same pathway, a different pathway. Now we go to the next one, confusion to clarity. Now, different mechanisms, beta blockers and calcium channel. I hope you remembered that slide, what I showed you. The beta blockers decreases the cardiac output, and calcium channel blocker decreases the peripheral resistance. So what is blood pressure? Blood pressure is cardiac output into peripheral resistance. So if you reduce cardiac output in one pathway by beta blocker and the other pathway calcium channel blocker, the blood pressure is reduced. So different mechanisms preferred in coronary artery disease, demand angina, high blood pressure, pregnancy and hypertension. Not preferred in diabetic nephropathy. So this is the different mechanisms preferred in these 2 conditions. Now, don't combine beta blocker with non-dihydropirin calcium channel blockers like verapamil or diltiazem. Now the different mechanisms. Again, beta blocker decrease cardiac output, angiotensin inhibitor decrease peripheral resistance. This is preferred in CAD, post-MI, LV dysfunction, heart failure, and then diabetes and coronary artery disease. This is not preferred to achieve targets in severe renal failure. It is not preferred. It's not a good combination in a simple hypertension. But now we got even commercially available beta blocker and ARBs are available. And now different mechanisms, third stage, that is decrease cardiac output by beta blocker, decrease PR by alpha blocker. This is preferred in accelerated high blood pressure due to sympathetic overaction, coronary artery disease with benign prostatic hypertrophy, renal failure, renal and heart failure, and cardiorenal syndrome. So here we give carvedilol. So not preferred in hypertension mediated organ damage prevention. So it's not given preferred there, but preferred in these conditions where beta blockers and alpha blockers combination can be given. As I told you, this is different mechanism. Beta blockers reduce cardiac output, alpha blockers decrease peripheral resistance. Now, different mechanism, fourth category, diuretics and calcium channel blocker. This is combination. This decreases cardiac output, diuretics, and calcium channel blocker decreases peripheral resistance. Preferred in ISH in elderly, isolated systolic hypertension in elderly, prevention of strokes. There are a lot of studies have shown that diuretic calcium channel blocker can prevent strokes also in an elderly person. In not preferred in HMOD prevention, diabetic nephropathy, and then CAD. Now, different mechanisms, 5. Diuretics and angiotensin inhibitors. Like, they also decreases cardiac output, decreases PR, preferred in achieved targets, LV dysfunction, and diabetes. Not preferred in elderly hypertension and severe renal failure. And spironolactone plus angiotensin inhibitors in heart failure. Now, different mechanisms summary. I already told you beta blocker, calcium channel blocker, beta blocker, angiotensin inhibitors, beta blocker, alpha blockers, diuretics and angiotensin inhibitors, and then diuretics plus calcium blockers, diuretics plus alpha blockers. So these are the different mechanisms summary. Now, coming to the same mechanism. I told you different mechanisms, you understood how it reduces cardiac output and the peripheral resistance. Now we come to the same mechanism, but different pathways. See, beta blockers reduces contractility, diuretics decreases preload, volume. So these same mechanism, these combinations also can be given, beta blocker to diuretic, in an uncomplicated high blood pressure without HMOD, without hypertension mediated organ damage. This is not a preferred combination in diabetes mellitus or metabolic syndrome or obese hypertensives. This is a combination which to be avoided in the metabolic syndrome and diabetes or obese hypertensives. Now, the same mechanisms, different pathway. One is the angiotensin inhibitor and then calcium channel blocker. Both are the same pathway, reduces the peripheral vascular resistance. This is reducing the vascular hypertrophy, whereas calcium channel blocker, vasoconstriction. This is preferred in achieve the targets, HMOD prevention, in diabetes, high blood pressure, nephropathy, CAD, and then obese metabolic syndrome, prevent future DM, and not preferred in elderly hypertension. Now, calcium channel blocker, edema is less, ACE inhibitor, cough is less. So when you give angiotensin inhibitor and calcium channel blocker, the side effect of the calcium channel blocker edema is less. Again, side effect of the ACE inhibitor, cough is less. Now, the same mechanism, different pathways. Again, angiotensin inhibitor and alpha blocker, it reduces vascular hypertrophy, vasoconstriction, preferred in effective BP lowering, where angiotensin in calcium blockers can't be combined with BPH, the diabetic nephropathy, not preferred in elderly. Now, the same mechanism, different pathway, calcium channel blocker and alpha blocker. Again, calcium channel blocker decrease intracellular calcium. Alpha blockers block alpha stimulation, preferred in renal failure, prostate hypertrophy, bronchial asthma, and peripheral vascular disease. Not preferred in elderly, CAD, and DM. So, calcium channel blocker and alpha blockers also can be combined, especially in BPH and renal failure. Now, coming to the same mechanism summary. Beta blocker plus diuretic to be avoided in metabolic syndrome and diabetes. Calcium blockers with angiotensin inhibitor is the best combination. The best combination is calcium blocker and angiotensin inhibitor, especially beta blocker and calcium channel blocker and ARB is the best combination. Angiotensin inhibitors plus alpha blockers and calcium blockers from alpha blockers in the renal failure. Now, the same mechanism, same pathway. I told you the cardiac output can be reduced by reducing the preload. How do you reduce preload? By giving diuretics. What are the diuretics we use? Thiazide diuretics, loop diuretics in heart failure and hypertension, high blood pressure. Thiazide diuretic, aldosterone inhibitors. Then loop diuretic and also aldosterone inhibitors in heart failure. Or PR, calcium channel blockers and the dihydropyridine and non-hydrodipyrid like verapamil or diltiazem also can be given. But usually ACE and ARB should be avoided. So this is same mechanism, same pathway. Now the other combination of centrally acting drugs like alpha-methyl dopa and hydralazine. Now the methyl dopa is not available in many places. We used to give in the pregnancy hypertension and renal failure. So hydralazine, combination of methyl dopa and hydralazine in pregnancy, and clonidine and diuretics in a severe hypertension and renal hypertension we can give. Other than antihypertensive, aspirin and statins also we combine in many of our hypertensive patients to reduce the risk, cardiac risk. Now, single drug combination off-label, sacrobutyryl and valsartan in ARNI, in heart failure, LVD, and hypertension, resistant hypertension, replacing ACE or ARB. Hydralazine and nitrates, again a good combination, heart failure with hypertension. In a heart failure with hypertension, hydralazine nitrate is a good combination. Even the commercially, the combination of the drugs are available. In CKD, resistant hypertension, and ACE and ARB intolerant patients, hydralazine and nitrates can be tried. Now, the third drug selection. Now, having told you about how two drugs are selected, how do you select the third drug? The first choice, diuretics, if not already used in initial combination. I told you, if there are two drugs, you use diuretic, and even then, if it is not controlled, it is called resistant hypertension. In CCBs, when initial combination of diuretics fail to control BP, or beta blocker when evidence of sympathetic overdrive, SOD, sympathetic overdrive is present, for example, high heart rate, premature beat. Then, apart from the two drugs, you can add beta blocker as a third drug. Or if you have not tried ACE and ARB as the first two drugs, you can try ACE ARB, rare in the third step, when compelling indication is identified like albumin or left ventricular dysfunction. Now, how to select the fourth and fifth drug in combination therapy? Friends, just remember this algorithm, very important for you to select the fourth or fifth drug. What is it? First, in the three drugs, you optimize diuretic therapy. Okay, I have done optimized diuretic therapy. Sir, I didn't get the control. So you can select spironolactone if the three drugs, no improvement in a resistant hypertension, which is called as resistant hypertension. You can use spironolactone provided potassium is less than 4.5. Okay, if the heart rate is more than 70, in that condition, you can use beta blocker. Sir, beta blocker, okay, my patient has got less heart rate. What do you prefer? Then you can use alpha blocker, and potassium is 4.5, then more than 4.5, you prefer alpha blocker, because you cannot use spironolactone if the potassium is more than 4.5. If the heart rate is more than 70 in spite of beta blocker, instead of beta blocker, we can give clonidine. Even then, there is no improvement. You can add the fourth drug, vasodilators, like hydralazine, nitrates, or minoxidil. Minoxidil is also good antihypertensive drug. And minoxidil externally we use for hair growth. But the minoxidil as a drug in the direct vasodilator, as a fifth drug or fourth drug, is very good. And if there is all the five drugs we use, if there is a refractory hypertension, then you optimize beta blocker, because refractory hypertension is usually sympathetic related. The resistant hypertension is usually due to volume problem. So if still you cannot control, then you refer the patient for a hypertension specialist. We can try renal denervation. Now, newer added drugs, SGLT2 in diabetic mellitus, CKD, heart failure, obesity, and OSA, obstructive sleep apnea. Obstructive sleep apnea is one of the cause for resistant hypertension, where you use SGLT2. Again, the spironolactone is also useful in OSA because it not only reduces the BP, it also reduces the upper laryngeal edema. Now, the new drug called finerenone, it is also used in CKD, diabetic kidney disease. Even finerenone can be used to prevent the progression of CKD in diabetes. Then heart failure with preserved ejection fraction and diabetes mellitus. So these are the newer and add-on drugs. Now, a word about what is fixed drug combination, what is flexible combination. See, fixed drug combination means you give telmisartan 40 milligram, amlodipine 5 milligram. That is fixed. Whereas flexible, you have to titrate. I give amlodipine 2.5 and telmisartan 80. So it is flexible. Whereas fixed, it is not possible. Complaints in flexible, not so good, because you have to alter the dose and all that. Fixed means one drug, single pill combination, easy. Compliance is easy. Cost is relatively costly, and fixed is cost effective. Chemical and formulation incompatibility, not an issue, maybe an issue. Individual drug timings and dosage intervals can be modified. It cannot be modified. For example, you can give one drug, the timing is different, another drug in the night. For example, suppose I give calcium channel blocker and ARB, I can give calcium channel blocker in the morning and then telmisartan in the night. It can be modified, it's not modified. So these are the difference between fixed and flexible combination. Now the many guidelines says single pill combination is good. Single pill combination of 3 drugs also is now available. Very easy, patient will understand, the adherence is better. Now, this is the triple big fixed combination. I already told you, triple drug combination depends on the clinical experience of single agents, ACE or ARB, amlodipine or indapamide. You will have to control and check adverse events and compliance, whether the patient adhere to the drugs. Now, the how not to combine. What are the drugs you should not combine? Combination to be avoided are beta blocker and diuretics, especially diabetes, ACE and ARB in a simple hypertension, beta blocker and clonidine for a bradycardia, beta blocker and non-hydroperin for again bradycardia, calcium channel blocker with diuretic in urination hyponatremia, ACE IRB with aldosterone inhibitors in hyperkalemia, alpha blockers plus CCB to be avoided preferably in elderly, BP with the calcium channel blocker in pheochromocytoma, and then diuretics with alpha blocker not used. So now the summary takeaways. Remember my topic combination, COMBINATION. So mnemonics of combination. Consider early combination. Over 80 monotherapy usually. Modify the combination according to the situation. Bad combination, be aware, avoid. Ideal combination according to disease. Never allow BP less than 120/70. Alternate new combinations aware. Third drug selection strategy, I already told you. Increase adherence. Overall BP target achievement. Need to maintain targets on a long term. It's not necessary. It's not easy. I mean, enough if you maintain only for a short time. Long term BP maintenance should be there. So track your blood pressure numbers together always. Then I am going to play Kahoot. I don't know how many of you know this game Kahoot. If you are using for the first time, take your mobile phone, go to Play Stores, look for Kahoot, download the app Kahoot, either in the mobile phone or the laptop. Download the app Kahoot in the Play Store and log in www.kahoot.it. After download the Kahoot, then I'll give you a game pin number. Then we can play the game. There is a Kahoot scan QR code also. Again, the future drugs, just a word about future drugs. The nice drug has come, zilebesiran. The zilebesiran is a novel drug that inhibits angiotensin production, reducing blood vessel constriction and lowering blood pressure with a single injection for up to 6 months. Very easy. You give one injection for 6 months, the zilebesiran acts and the blood pressure is under control. Then aprocitentan, the Trivio, recently introduced in the US and all, is an endothelin receptor antagonist approved for hypertension in combination with other drugs. Now, aldosterone synthetase inhibitors, example, lurnodorostate and baxdrostate, is a class of drugs inhibits the production of aldosterone, a hormone that plays a role in blood pressure regulation. So combine and conquer, and always teamwork plays. Now I'll play the Kahoot and then I'll come for the discussion. See, there are about 1,000 people here. At least I request 100 people to participate in the Kahoot. I already told you how to download Kahoot app in the Play Stores and then wait for my game pin number and then you play along with me. So there'll be an interesting game. Just 12, 13 questions. Every question we give you only 10 to 15 seconds. Here actually we are giving 20 seconds and we can always get the answer. Whoever answers correctly in shortest time will get more marks than a person who answers little later. And no identity will be there. Even if you commit mistakes, don't worry. It's a fun and you learn the game with the fun. So I will now start the Kahoot. I'll give you, get ready to join. I'll give you the game pin number. And once the game pin number is 624923. So this is the game pin number. You will have to log in, join Kahoot with the Kahoot app or the scan the QR code. Very good. There are a lot of people now know about Kahoot. They started now, joining. I'm very, very happy. I could see all my good old friends who come to me program regularly. Now they got very well knowledge about the Kahoot and they always play a good game. I think Dr. Sendil, the CGP secretary, should also recognize these people who are winning the Kahoot by special gifts. Sendil, I don't know whether you are aware. Sendil, are you there or you are sleeping? Sendil, are you there? Sendil CGP? Okay, I'll give you another 30 seconds more for you to join. I'm happy. So many people have joined Kahoot. Paneerselvam, are you there? Paneerselvam? Our
Sir,
moderator,
sir.
Paneerselvam, Bavdarni, are you there?
Sir, I am here.
Okay, very nice. But Paneerselvam is not there, I think, no?
Sir, உங்களுக்கு முடியும் போது சொல்லுங்க சார். நம்ம டாக்டர் சுந்தரம் தான் அடுத்தது.
Okay, fine. Now I'll play the game. We'll start the game now. So you can join even after I start the game. I'm glad so many people have joined. Now I'll start the game. I'll count 3, 2, 1 and start the game. 3, 2, 1. Huh? Why is the combination therapy often preferred over monotherapy in hypertension? To reduce side effects, to counteract compensatory mechanism, to save cost, to increase drug tolerance.
நான் அதுல போகவே இல்லை.
Very good. See, it is because to counteract compensatory mechanism. Let's see who's number 1. I think Sharain and Aruks and MD, number 1 and 2, 3. Now, second question, which combination is preferred in elderly patients with isolated systolic hypertension? Elderly hypertension, beta blocker with CCB, ARB with beta blocker, diuretics with calcium channel blocker, or calcium channel blocker plus alpha blocker. Super. So diuretics plus calcium channel blocker is preferred in ISH. I already told you it can also prevent stroke. So now we'll see Shrain. No, now CD 117 Praveen Kumar leading. The third question, what is a common side effect of CCB that can be reduced by combining with ASRB? Headache, cough, or edema, or bradycardia? Very simple question. I think all the 75 people who are joined must get the correct answer. Very good. To reduce edema. See, that is why counter-regulatory mechanism, when you combine calcium channel blocker, the edema is there in one of the calcium channel blockers, more so in amlodipine. When you combine ACE, the edema is reduced because of the combination. That is the advantage of combination therapy. Pavitra Selvam, number 1, Praveen 2. Now, fourth question. Which combination should be avoided due to the risk of bradycardia? Beta blocker with non-dihydropyridine CCB, or ARB with CCB, diuretics to ARB, or alpha blocker with ACE inhibitor. And there are more than 80 people have participated. Very good. I think good numbers to participate in the Kahoot. Super. So beta blockers and non-HTP usually to be avoided because beta blocker also reduces reduce the heart rate. Again, verapamil and diltiazem also can do the same. So you should not use this combination in bradycardia. Pavitra still leading, ECGA number 2. Now, fifth question. Which of the following combinations is preferred in patients with CAD and BPH? ACE plus diuretic, ARB plus CCB, beta blocker with alpha blocker, CCB with diuretic. Which of the following combinations is preferred in patients with coronary artery disease and benign prostate hypertrophy? Again, simple question, because we use this drug for, very nice. Beta blocker and alpha blocker. Alpha blocker is always given even for the prostate hypertrophy. Now, let me see who's now Pavitra is second, EC is second, first. Sixth question. What is the best combination for patients with diabetes and nephropathy? ARB, CCB, CCB with alpha blocker, beta blocker with diuretic, loop plus thiazide diuretics. Combination for diabetes and nephropathy. Is it ARB, CCB? I think next question. Pavitra with Sundarapandi. What is the mechanism of diuretics in blood pressure control? I told you the first slide. It decreases peripheral resistance, decreases heart rate, decreases cardiac output preload, or increase contractility. The mechanism of diuretics in blood pressure. Super. Decreases cardiac output preload. The other drug now, Pavitra, Sundarapandi, and Vishnu. Now, 8th question. Which combination is discouraged in simple hypertension? In a simple hypertension, you need not give ACE and ARB or CCB plus diuretic or diuretic plus alpha blocker or ARB plus beta blocker. In a simple hypertension, this is not to be encouraged. Oh, 82 people have participated. Very good. So ACE and ARB not to be encouraged for simple hypertension. Pavitra, Dani, and Shah. 9th question. What third drug is generally added when initial dual therapy fails? CCB, ARB, diuretic, or beta blocker. The third drug, generally, if you start with 2 drugs, the third drug usually is diuretic. Oh, not bad. Now about 88 people have joined. Nice. So Pavitra and Dani and Shah. Now the 10th question. Which fixer combination improves compliance best? Flexible dosing combination, single pill combination, triple free combination, dual IV therapy. I told you the difference between single pill and flexible. And that slide also I told you the compliance is best in which of these following 4. In single pill combination, the compliance is best. Now, Dani and Pavitra. Now, 11th question. Which of these combinations is effective but must be avoided in diabetic patient? Beta blockers plus diuretic, ARB, CCB, ARB plus diuretic, CCB plus diuretic. This combination is effective, but to be avoided in metabolic syndrome or diabetic patients is B and D, beta blocker and diuretics. Very good. Now, Sundarapandi is good. C. Now, 12th question. Which newer drug offers long-term BP control with a single injection? I told you last slide. Silbizarone, clonidine, amlodipine, indapamide. With single injection is a... Oh, more than 89, 90 people have participated. Super. I think in every question, more people are answering. Very nice, very nice. 67 people answered Silbizarone. It's very, very good. Then Dani, Sundarapandi is still leading. The last question of the program. Which of the following is used in resistant hypertension as a 4th line agent? Spironolactone, CCB, ARB, alpha-methyl dopa. Oh, it has touched more than 90 now. Super. Spironolactone is the 4th line drug. And you must, whenever you use spironolactone, check the potassium. If the potassium is more than 4.5, don't use spironolactone. Now, let us see who is the winner. Sendil, are you there? Sendil? No.
Yes, sir. Yes, sir. I'm here, sir. Yes, sir.
Kindly note who is the winner. 1, 2, 3. You kindly
Okay, sir. Yes, sir. Yes, sir. It's recorded, sir. We will take it from there, sir. Yes,
yeah,
sir.
Pavitra is number 1.
Pavitra.
And then second is Sundarapandi, third is Dani, and 4th is
Okay,
Sri.
sir.
Excellent. More than 90 people have participated, Sendil. I think
Yes,
first
sir.
time you are using Kahoot in your CGP conference, no?
Yes, sir. Yes, sir. First time, sir. Thank you so much, sir. It is very interesting, sir. Yes, sir.
Yes. So they've already said claim rewards. Okay, you have to get claim rewards from Sendil.
Yes, sir. We will do, sir.
Sendil
Yes,
is an
sir.
aggressive person. He's from Pollachi. So I can give you his address and phone number. Those of you who want to talk to him, you can talk to him and directly get the certificate or rewards. So
Wonderful,
now
sir.
over to
Interesting.
you. Over to Paneer
Sir.
Selvam and Bhavarni.
Sir, thank you, sir. We all enjoyed not only your hypertension talk from pathophysiology to various mechanisms and various drugs, its mechanism of action and combination, not to combine, when to combine, how to combine, and lastly, your question, very
Kahoot, sir.
Highlight.
Yeah, Kahoot. So we all enjoyed thoroughly, sir. There are some questions, sir.
Yeah, please.
So Indirol, regarding Indirol, they are asking, sir, whether to
Okay.
use Indirol or not.
Yeah,
So I think
Inderol.
they cannot. Please, sir.
Yeah, Inderol is a beta blocker. Now we don't use
Yes,
Inderol
sir. Yeah.
very
Non-selective beta blocker.
yeah, but it is now used in migraine. In migraine prevention, we use
Yes, sir.
Inderol, and in a hepatic problem, sometimes they use in a tachycardia. In a tachycardia, because it is an antiarrhythmic drug. It is a membrane stabilizing drug. So in arrhythmias, beta blockers, Inderol is used. In prevention of migraine, we use beta blocker. This is a non-specific beta blocker. So that's why we don't use now.
Non-selective beta blocker we rarely use now.
Yes. But we are using it in migraine
have
and
better
also
beta
arrhythmias. In arrhythmias, we use. Yes. In
Not
fact,
for hypertension.
yeah. Then
I don't think we have any other questions, sir. Or if somebody wants to ask some question also, they can unmute and ask.
they can usually put
And
questions.
sir,
Okay.
another important clinical findings are recently, after adding SGLT inhibitor along with the diabetes and hypertension management, we are in a position to reduce antihypertensive if you use SGLT inhibitor for minimum 6 months to maximum 1 year. Sometimes we withdraw antihypertensive also. To that level, the SGLT inhibitors are helping our patients, sir. Earlier, while we are treating diabetic and hypertension, we have to upwardly titrate anti-diabetic drug as well as antihypertensive drug. Now, after introduction of SGLT inhibitor and gliptins, we are in a position to down titrate sulfonylurea and insulin for diabetics, or we are in a position to down titrate antihypertensive also among diabetic and hypertensive patients, sir. This is the positive sign. So, if you closely monitor SGLT inhibitor, we are not in a position to upwardly titrate the dose. We are downwardly titrating the dose. For example, etinol 50 milligram already the patient is on with amlodipine. We remove amlodipine. Then we reduce etinol to 25 milligram. SGLT inhibitor is helping for many of our diabetic with hypertension, sir.
Yeah, SGLT is a game-changing molecule we use in many cardiac conditions.
Yes,
and
sir.
even in a resistant hypertension, the recent papers have come. SGLT with the RNA combinations also they're trying. And it's a good drug. And one more caveat is, whenever somebody with hypertension, when you give SGLT, check the blood pressure, because as you said, it may reduce the blood pressure, but not very, as a single drug, it is not a good drug to reduce blood pressure. In a combination, it may reduce more.
Along with other drugs.
Yes. Okay.
Yes, sir. Because it persistently throws away the excess water, sodium, along with some amount of glucose.
Yeah.
So the preload and postload is getting reduced. So it is very useful drug for.
And it is also used.
So one of the comment is useful.
Yeah. Go ahead, Paneer.
Yes,
Go ahead. One of the comments.
One comment is useful presentation. Even beginners can understand. Like that, one doctor has commented, sir. So they have enjoyed your talk very well.
Okay.
As usual, we all enjoy your talk.
But Paneer, this Dr. Sendil only informed me yesterday. He informed me about 3 weeks back. I totally forgot. My secretary also forgot. Yesterday,
Yes, sir.
tomorrow is your talk, he said. I said, no, I didn't. 3 weeks back, I reminded you, I reminded your secretary also. But secretary was good, so she did not remind me. So yesterday,
Hypertension, even if we wake up in the night and ask also, you'll start.
Of course, that he will talk, but time management is important because he is committed to so many.
So many programs, sir.
Today I have got 3 programs. After this, we are talking, Meena Sundaram is talking about numbness. And then after that, Ram Subramaniam is talking about infection. So
Infectious disease.
lined up today. Anyway,
Yeah.
so thank you very much. I enjoyed.
Sir, yes, sir. We all enjoyed, sir. Thank you,
1,000
sir.
people are there. Thanks, Sendil.
Yes, sir. Thank you so much, sir.
Thank
Yes,
you,
sir.
Parag. Yeah.
Thanks for your time, sir. Yes, sir.
So I can leave now. I can leave
Yes,
now.
sir.
Yes, sir.
Yes, sir.
Fine,
Thank you, sir.
Yes,
Thank
sir.
you, sir.
Thank
Thank
you,
you
sir.
for your
Yes.
presence and presentation, sir.
Yes.
Thank you.
So now we'll move on to third topic. Third topic is, I think that Bhavani, you are going to operate from your end, changing the slide. Unmute.
Yes, sir. Yes, sir. I will put the slides for sir.
Right. Sir, Dr. Sundaram sir is a teacher of us, Dr. Bhavadharani and myself, and he was a teacher for more than 4 decades, involved in diabetes specialty for more than 4 decades. He worked in diabetes department of GH as well as Hill Park Medical College, and we enjoyed his teaching 35 years or 40 years before. He is going to talk on basics, blood sugar, blood vessel, and beta cells. Of course, once you maintain the beta cell well or islet cells well, the blood sugar correction will be there and your blood vessel will not get affected, whether it is microvessel or macrovascular. So we is going to talk on this topic today. So blood vessels, blood sugar, as well as beta cells. Over to Professor Sundaram sir.
Thank you very much, Dr. Paneer Selvam. My topic is always basics because there is a lot of confusion about diabetes. Recent advancements made us to think differently, but basics will never change. The 3B link.
Sir.
Next slide, please. Bhavadharani.
Anatomy and physiology will not change, sir.
Yes. Bhavadharani? Yes. Suppose somebody
Yes,
has
sir.
a fasting blood sugar of 90 and PP 240 and fasting blood sugar of 180 and 320. We immediately think to treat the patient. But I would request you to link 3 things. Next, press. So you must change the concept from blood glucose control to link changes in 3 organs. Blood beta cells, blood sugars, and blood vessels. Why? You can preserve beta cells, you can preserve blood vessels, and you can preserve organs. Next. Next, please.
Sir, அது கொஞ்சம் slide.
Next one. Yes. My objective will be on 5 aspects. I will talk to you about beta cells, insulin secretion, and so on. Fasting blood sugar and its effect on beta cells and blood vessels. Similarly, the postprandial blood sugar. And then endothelial dysfunction, atherosclerosis, and correlation of all. And what are the practical points that we will have to take? Yes, next. We are all crorepathies. We have about 10 to 30 crores of beta cells. Beta cells are capable of changing blood sugar, secreting insulin when there is a change of blood sugar from 80 to 82. That is the sensitivity of beta cells. They can store as much as 200 units of insulin. The fasting insulin level is around 20 international units. This 10 times more insulin can be secreted after a meal and blood sugar can be brought on. That is the meaning for it. Can secrete about 40 units per day. Next, yes. Insulin secretion is of 2 types. One is meal stimulated insulin, the other one is basal insulin secretion. The meal stimulated insulin secretion occurs the moment you enter and think of a good food. The stored in preformed insulin is released. That will control rising blood sugar immediately. It may last up to 15 minutes. The second phase starts from 15 minutes to 120 minutes, and then the blood sugar is maintained within normal limit. Whether you eat or not, some amount of insulin is secreted. That is called basal insulin. This basal insulin is secreted at a rate of 0.5 units per hour. That means in a day, you can expect 12 units of basal insulin secretion for throughout 24 hours. What is the function of this basal insulin? Is to control hepatic glucose output and also fasting blood glucose. We all take 3 meals. With each meal, there is a rise in blood sugar. That's the blue panel. With each meal, the blood sugar rises. That concept we love to give to our clients. Along with the glucose, with each meal, insulin is secreted. If you look at the top panel where the insulin secretion is more 14 to 17 units per post-breakfast hyperglycemia than post-lunch and post-dinner, this is because circadian rhythm that occurs early in the morning. So it is always very difficult for us to control post-breakfast hyperglycemia than the post-lunch or post-dinner hyperglycemia. And people always think that insulin alone maintains the blood sugar. Here comes the play of counter hormones. When you take food, the messages are sent to the brain, to the pancreas, from the pancreas to gut. This is called hypothalamo-enteroinsular axis. When you take a meal, insulin is secreted. And we always think that insulin alone maintains the blood glucose, but it is not like that. Glucagon, epinephrine, growth hormone, and HPL in pregnancy all tend to raise the blood sugar, whereas insulin tend to lower the blood sugar, and the normality is maintained. So counter hormones are always necessary. Without the counter hormones, it is very difficult to read about hypoglycemia. If you look at the pathogenesis of type 2 diabetes, two things are evident. One is beta cell related, other one is metabolism related. That's why it is called metabolic vascular disease. And beta cell related are insulin resistance, insulin deficiency, beta cell failure, and apoptosis. That means cell death. Metabolism related are hepatic glucose production increased. That's called glucotoxicity. Similarly, FFA is increased. That's called lipotoxicity. We always propagate heart failure, liver failure, kidney failure, and brain failure. We never propagate beta cell failure. Please propagate from day one of diabetes that your beta cells are failing. Tell your clients. Next. And we all know how to classify diabetes based on blood sugars. The postprandial, post-glucose load blood sugar, if it is above 140 but below 200, it is called IGT. Above 100 but below 126, it is called IFG in the fasting state. HbA1c more than 6.5 internationally for diagnosing diabetes. For Indians, it is around 6. We only read like this, but what is the purpose of doing this is, next please. If you look at you might be familiar with this picture, but if you look at the center where 0 and the white line, we detect diabetes at that time, 50% of beta cell mass is lost. And it is progressive. It does not stop there, and it is, please go back. And it is progressive. Over years, within 6 years, most of the patients will require insulin. If we extrapolate this backwards, there are some important things that appear to us. The process of diabetes, that is pre-diabetes, IGT, IFG, and the postprandial hyperglycemia starts some 10 to 12 years before the onset of diabetes. So that means 10 to 12 years before, you had 100% insulin secretion, 100% beta cells. When you develop IGT, when you diagnose IGT, 15% of beta cell mass is lost. When you develop IFG, another 15% is lost. With the PP hyperglycemia alone, fasting being normal, it is somewhere from 30 to 49% of beta cells are lost. Once you detect diabetes, it is 50% beta cell mass is lost. This gives us an opportunity. Knowing that diabetic process started some 12 years ago, you have a greatest opportunity of preventing IGT or IFG or reverting postprandial hyperglycemia alone to normal or IGT to normal levels, if you examine the family members and then try to adopt changes in lifestyle or diet or treat them and revert it back to normal. Beta cells are failing at a rate of 4 to 7%. Remember, 5% per year. So in another 10 years, everything will be lost. But now today, people, because of their culture and habit changes in diet, they require insulin within 3 years. Next one. Next, please. Next, ma. Bhavadharani. நீங்க என்ன பாருங்க இல்லைன்னா கையை பாருங்க. Right. Blood sugar is an indirect parameter for diabetes. Just like a thyroid hormone, thyroid diseases, we measure thyroid hormone, but for diabetes, we do not measure thyroid. When insulin is secreted, along with that, C-peptide is also secreted. With one drop of C-peptide is secreted. Insulin is metabolized by the liver, whereas C-peptide is not metabolized in the liver. So C-peptide becomes a marker for endogenous insulin secretion. How it can be used? Usually when you control hyperglycemia or glucotoxicity, and then only you should do diabetes. But there are certain patients who refuse to take insulin in the beginning, wherein my patient had 247 fasting and postprandial 350, and he is around 32 years. He refused to have insulin. When I did the C-peptide, look at the C-peptide values. C-peptide fasting must be more than 1.5, and the 2-hour value must be more than 2.5 picomoles. Whereas for this man, it was only 0.5 picomole and 0.57 picomole postprandially. So he comes under the category of poor beta cell reserve at that time. So when you give insulin, the beta cell functions can be restored. Now that this shows glucotoxicity can inhibit beta cell function. Next one. Next one. Next, we will see beta cells and insulin secretion versus fasting blood glucose. Yes. When you give glucose IV, we get two graphs. First phase insulin secretion and then the second phase insulin secretion. The first phase insulin and the second phase insulin secretion. Look at the second phase. There is wide area beneath it. What happens in a diabetic when fasting blood sugar crosses 100? Is first phase insulin secretion is diminished or absent, and then when 180 fasting crosses 180 milligram, the second phase insulin secretion is also lost. Then you can ask me how people can live. This is where we love to learn that whenever we do GTT with glucose, it is glucose induced hyperglycemia. Whereas meal contains protein, end product amino acid and fatty acid for fat, they are also stimulate insulin. That's why we are all alive in spite of 200, 300 blood sugars. Next. Liver plays a major role in the pathogenesis of fasting and postprandial hyperglycemia by excessive production of glucose, hepatic glucose. This hepatic glucose production is normal in the fasting state, where insulin secretion is normal. Glucagon secretion is somewhat increased, but within the normal limit. This increase is required in the fasting state to send glucose to the brain when blood sugar is around 90 milligram. When the blood sugar crosses 180, insulin secretion is diminished, as we have seen earlier, and glucagon secretion is increased. There was a woman who came to me and asked, my fasting blood sugar is always around 135. It is not 115, 135. But my postprandial goes to 350 through 270 like that. Why it is so? When I take one dosa in the morning, one chapati or one idli in the afternoon and one chapati in the night, please tell her, even though she is not eating extra food, her liver produces glucose. This is the message you should give when blood sugars are not under control. Your liver produces excessive glucose even though you are not taking food. This is because of basal insulin deficiency. Next. Right. What is glucotoxicity? High blood glucose fasting more than 100 inhibits insulin release from the beta cells, inhibits glucose uptake in liver, muscle, and fatty tissue. Beta cells die whenever there is glucotoxicity. This glucotoxicity is reversible. Next one. This I will explain with a figure. The first figure on the left side shows at point number 1 interrupted dots. That means basal insulin secretion is less at 1. 2, there is hepatic glucose output increases. And 3, you have fasting hyperglycemia or glucotoxicity. Because of glucotoxicity, the pancreas will not secrete enough insulin. Muscle, liver, and fat cannot utilize glucose at all. Whereas in the right side picture, please, right side picture, at point 1, I give basal insulin, hepatic glucose output is decreased, fasting blood sugar is reduced. Now there is no glucotoxicity. Your meal or sulfonylurea or secretagogues can stimulate insulin secretion. Liver, muscle, and fatty tissue can utilize glucose. When there is high blood sugar levels, do not do acute exercise. Right. Next, please. Then what happens when blood glucose, as I told you in the pathogenesis, beta cell apoptosis takes place. When it occurs, we will see. As the fasting blood sugar goes from 100 to 180 or 270 or 360 like that, in the beta cell, there is a white substance deposited on the left side. You see there is one beta cell in which there is lots of white substances, that is the amyloid. On the right side picture, it is shown in the form of blue deposits. These amyloids secrete a substance called ceramide that kills the beta cell. So, whenever there is glucotoxicity or blood sugars are high, amyloid is secreted, and that from the amyloid, ceramide kills the beta cells. That's the mechanism. Next one. How all beta cells can get reduced in number as the days progresses? There is a reduction in the number of beta cells because of the age-related or genetic. It is genetically programmed. And exhaustion of hyperstimulated beta cells by our insulin secretagogues and uncontrolled glucotoxicity. Then we have seen the alteration in the structure of the beta cells or the islet by the deposit of amyloid. I've shown you here a picture in 1995, 300 patients, first degree relatives who had blood sugars, GTTs done, and you see the fasting blood sugar is always around 80. 1 hour value is less than 140, and 2 hour value is less than 140. Now the fasting blood sugar has gone up to 90, 95 like that, and the 2 hour value is around 140. This why I have projected this is family members who have diabetes and their children born will have reduced number of beta cells from earlier age itself. Next one. Next, please. Baudarni. Pochra. Then we will see PP blood sugar and its effects on beta cells. Next. Next, please. Right. Here you can see the graph of 2 patients. Both the patients, the yellow line and the pink line, both have fasting blood sugar of 90. What happens to the yellow line? Into the yellow line, with first 1 hour, glucose is absorbed, maximum insulin secretion occurs, and then insulin takes the glucose inside the cells. This is called normal insulin sensitivity. The 1 hour value never crosses 140. And if it crosses above 155, it is called early glucose intolerance. If you do a GTT in a family member and the 1 hour value is above 155, rest being normal, then this person is going to develop diabetes in future. And then the second pink one, for 1 hour value is around 200, then it comes to 240, 260. It goes on increasing. It never comes down. That means there is no insulin secretion. There is insulin resistance. Glucose does not enter into the cells. Why it is important is 20% of diabetics have only PP hyperglycemia. That is very important in our people. Fasting being normal. So never check fasting alone and say you are not a diabetic. Check PP also with glucose. Next one. So the first abnormality as per the previous one is 155, 1 hour value. Basal hyperglycemia and basal hypoinsulinemia is explained in this slide. The lower panel, fasting is around 90. You look at the pre-meal blood sugars. Pre-meal, pre-lunch, pre-lunch and pre-dinner are around 90. This is called normal basal insulin secretion and normal basal blood sugar. Please go back. Please go back. Normal basal insulin secretion. At that time, the fasting insulin is around 20 international. If a person has got 200 fasting, the PP peak goes up to 360, and then 2-hour value or after before lunch, it comes to 200 only, maybe 10 to 20% on either way. The pre-dinner is also similar. If a fasting is more than 200, please remember, even without doing the pre-lunch and post-lunch, the post-dinner blood sugars will be high. Pre-dinner and pre-lunch blood sugars are also high. At that time, the fasting insulin secretion is around 10%. Next one. Then we will see what is endothelial dysfunction and atherosclerosis versus increasing blood sugars. Next. When you inject acetylcholine into the brachial artery and see for vasodilatation, in a normal man, there is 3 times more vasodilatation than a person with IFG. That means fasting blood sugar more than 100, but less than 126, 120, or up to 125. 1/3 of the 1/3 only it has got expansion. This is the earliest stage. Don't think blood sugar alone, you may develop diabetes. No, you may develop endothelial dysfunction as well. When with regard to postprandial hyperglycemia, we'll have to see 2 things, metabolic effect and vascular effect. The metabolic effect is hyperglycemic stress. The vascular effects are because of the stress-induced endothelial dysfunction, atherosclerosis occurs in IFG, IGT, and that becomes more aggravated in type 2 diabetes. So these are the changes that are taking place in the blood vessel when there is hyperglycemia. Right. Next one. Bhavadharani, please. People thought that with the postprandial hyperglycemia only, when there is hyperglycemia, it will impinge upon the endothelial surface. So there will be 3 times. Breakfast, lunch, and dinner, post-dinner, there will be endothelial dysfunction. But, next slide, please. People studied, please look into this diagram. The ash color is the postprandial state, and the post-absorptive state is shown in red color, and then fasting will come in white color. Now, what is this post-prandial state? Somebody has got a blood sugar of 240. This 240 may become 220 or 180, but it is pre-lunch hyperglycemia. And that pre-lunch hyperglycemia, it takes meal. Post-lunch hyperglycemia occurs. That is carried on to the dinner. And then throughout up to 4 a.m., blood sugars remain very high with postprandial hyperglycemia. Then press again. Press. Right. Now, from 4 a.m., you get the fasting hyperglycemia. So, with uncontrolled postprandial blood sugar, we are in a state of postprandial hyperglycemia for more than 18 hours. This is very important. More than the fasting, it is the postprandial state that is more important for vascular damage. Next one. Now, if you think how these vascular defects occur, normal vascular endothelium is shown, a cut section of the blood vessel is shown there, and then on the top of the cut layer is the endothelium. The endothelium is very much intact. The cells are intact. There is no space for entry of any formed elements from the blood into the muscle layer. There is a laminar flow of blood inside the lumen of the blood vessel. Now, in the vasculature, muscle vasculature, 2 things are important for us. One, nitric oxide that is shown here. This is a vasodilator, and endothelin, which is a vasoconstrictor. One side endothelium constricts, and other side dilatation takes place. So this goes on alternatively, and then blood flows laminar flow. There is nothing to enter because of anti-adhesive substances at the surface of the endothelium. Now, in 3 conditions, diabetes, hypertension, hyperlipidemia, what happens is the endothelial surface is broken down. The formal elements and the lipids enter into the cells. Nitric oxide level becomes less, endothelium level becomes more. So this endothelium contraction is much more. There is hypertrophy of the blood musculature, blood vessel musculature, and there is inner diameter of the blood vessel is reduced. So atherosclerosis forms. Next one. What is the relationship between atherosclerosis and diabetes? For many diseases, inflammatory markers are same. In the same way, by a new etiology called common soil hypothesis, they found out the inflammatory markers in both the conditions, diabetes and even IgT, IFG, diabetes and atherosclerosis, C-reactive protein, interleukin 6, tumor necrosis factor alpha, vascular cell adhesion molecules, and intracellular adhesion molecules present in both. These inflammatory markers are more when there is glucotoxicity. And that's why patients with IgT, IFG develop stroke or micro and macrovascular, both can occur. Next one. This is just to say IFG or IgT because of endothelial dysfunction and atherosclerosis in pre-diabetic stage itself, they are associated with an increased risk of CVD. That is shown by the study called DECODE study. Next, please. Right. What happens to the fasting HbA1c level at the diagnosis when 6 or 6.5? People have detected 14 to 15% of retinopathy and some neuropathy, albuminuria in others. So when HbA1c crosses 6.5 internationally and 6 in Indians, there is retinopathy changes in the blood vessel. So microangiopathy is associated with the onset of diabetes. Next one, glucose intolerance. Next. Right, let us see. Let us try to correlate insulin, blood sugar, macrovascular disease in the development of type 2 diabetes. If you look at the base of the triangle, there is normal glucose metabolism, 100% insulin secretion is there, insulin sensitivity is 100% on the left side, and then only 10% of people have atherosclerosis due to age group. In IgT, there is more insulin secretion, but insulin sensitivity is reduced, and about 40% of people with IgT or IFG will have macrovascular disease. The tip of the triangle, that is called tip of the iceberg, we see when there is hyperglycemia or fasting more than 126 or 2-hour value on your glucose tolerance more than 200, we have 50% of people, 50% of beta cell mass is reduced, insulin secretion is less, and insulin sensitivity comes to 30 to 50%, and more than 50% of people have macrovascular. This is the correlation. Next one. Right. So this correlation is explained by a clock called ticking clock hypothesis. The clock starts ticking before the macrovascular disease, before the onset of hyperglycemia, and for the microvascular disease after the onset of diabetes. So the diagram is divided into 2 portions vertically. One is IgT, the other one is onset of overt diabetes. And horizontally, it is divided into 3 columns. First, the orange one, then the blue one, and then the red one in the lower one, showing the blood vessel involvement. The treatment response becomes more with IgT, and then as over diabetes over years, it becomes reduced. The insulin levels increases, this endogenous insulin, from the onset, it starts declining. At the same time, fasting blood sugar goes on increasing over a period of time. So the IGT is associated with macrovascular disease, and the onset of diabetes is associated with the microvascular disease. This is how we should correlate. Next one. Right, I've shown 3 blood vessels here. On the extreme right, you have an atherosclerotic vessel with reduced lumen. The center one is normal. Even though you are normal, you are not doing any physical activity, you are not doing, you are a fully stressed individual, then also you can have changes similar to that of an atherosclerotic person. Now I have shown a blood vessel here and with some sugar and insulin crystals. Next, press. All right. Next, there is lipids, and then contents, RBC, platelets, WBCs, RBC, platelets, and there is viscosity of the blood. So diabetes means for me, there is increased blood sugar leading on to IGT diabetes or IFG diabetes. Then we have increased thickness of the walls leading to hypertension, macrovascular disease. Number 3, you have what is known as hyperlipidemia. The characteristic features in diabetes are increased LDL, decreased HDL, increased triglyceride, and that is hyperlipidemia. Fourth one is the contents of the blood, WBC, RBC, platelets, fibrinogen, all are affected. How? WBCs are required for phagocytosis. That becomes defective. Wound healing becomes defective. RBC should take oxygen and nutrition to the cells, but it becomes defective. Deformity of the RBC occurs. And then platelets form a Rowley formation, so they may block the vessel. There is increased viscosity because of there is increased fibrinogen and thromboplastin A. So this increased viscosity or the thickness of the blood, when there is hyperglycemia, the blood becomes more thicker and the formed elements are affected. So please remember the container, that the blood vessel as well as the contents, WBC, RBC, platelet, everything is affected in diabetes, and these 4 changes are a risk for thrombosis. All these changes occur, press again. All these changes occur when there is glucotoxicity, when the blood sugar crosses 100 fasting, when there is asymptomatic. So we may have to treat all the 4 and caution the patient from the beginning. Next one. So my definition of diabetes will be, diabetes is a blood vessel sugar disease. Same. Why? We say blood sugar disease, they look for the sugar only. They do not care for their blood vessel. In fact, you'll have to save your endothelium for doctors. Next one, please. Right. So far, we have seen changes in insulin secretion first phase and second phase, hepatic glucose output, glucotoxicity, amyloid deposit, beta cell apoptosis, changes in the contents of the blood vessel and the container of the blood vessel. All these things lead to endothelial dysfunction and then blood vessel changes. Then please go back. Go back. No, all right. Next slide. Next slide. What we should do? What are the practical points? You must change your concept. That is what is more important. Teach the table concept to all your patients. The table has got 4 legs: diet, exercise, drugs, and insulin are the 4 pillars of the treatment for diabetes. And the top, without top, it is not a table. So the top is continuous monitoring and continuous education. All are interlinked. What you should also tell them is, people concentrate on taking drugs or insulin, but forget to follow diet or physical activity or lifestyle changes. But tell them diet and exercise or physical activity reduce 2/3 of blood sugar, whereas insulin and drugs will reduce only 1/3 of the blood sugar. So the more importance in the treatment should be given to modified meal plan and lifestyle changes. Next, please. Next one. No, one more slide has gone. Please go back. Go back. Sorry. Right. Later on we will see. Organ concept. Why modify meal plan? You will suggest them or reduce your diet. People
The
will not
organ
follow.
பின்னாடி வரும் sir.
It will come. Why should you do exercise or walk, and how to convince them? We just tell them do this so the sugar will come. But how the sugar comes down, you will have to explain to them. Next one. Next one, please. Bhavadharani, next. Right. Please. No, one more. You press backwards. Right. Press again. Right, it's all right. Look at the lower picture. When you take food, insulin is secreted. Insulin is shown in triangles, blue triangles, and then glucose in yellow circles. These two come via the blood vessels and reach the cell surface. On the cells, the insulin gets attached to the insulin receptor. The insulin receptor takes the insulin inside the cells, and then there is a group of glucose transporters, and they are broken down, and they come to the surface and take the glucose inside the cell. So for glucose to enter into the cell, we require insulin receptors and glucose transporters. These two things are defective in diabetes. So when you reduce food, when you increase activity, both will increase the number and activity of the insulin receptors and glucose transporter. And that's how you must tell them from the blood vessel, the glucose must enter into the muscles, liver and fatty tissue, muscle, fatty tissue and the liver. So you will have to follow them. Next. Right. This organ concept is very clear. Can you press go back? No, right. All right. I've kept one by one. It's all right. Just wait. If you look at the organs alone, you got the gastrointestinal system, beta cells, liver, muscle, and fatty tissue. They are called insulin action sites, and then the target organs. Now, when you take food, the glucose comes, stimulate the glucose receptors on the beta cell, insulin is secreted, and the secreted insulin goes to the muscle, liver, and fatty tissue for metabolic needs, and via the blood vessel, it reaches the organs. And we'll have to, it reaches all organs, but we'll have to say eye, heart, kidney, and the legs. This is the first part of it. The second part of it, if you know these are called the diabetic organs, please go back. These are called diabetic organs. You can remember whatever the drugs acting sites. You have alpha glucosidase inhibitor from the gut, and then DPP4 inhibitor, GIP, GLP-1 receptor agonist on the left side, that is from the gastrointestinal system. Insulin releasers or secretagogues acting on the beta cell. Insulin sensitizers, metformin pioglitazone acting on the liver and fatty tissue, and then you will have to save these organs. They may go and act on these organs. But what is the difference between these drugs and SGLT2? All the other drugs will try to push the glucose inside the cell, whereas SGLT2 inhibitors will push the glucose through the kidney outside the body. So that is how that's how they are different, and they are supposed to protect the heart and kidney. But if some damage occurs, how this damage occurs? There is damage, dysfunction. Please wait. Damage, dysfunction, failure of various organs. Okay, so this occurs in stages. Suppose if you detect somebody with microalbuminuria or albumin less than 30 milligrams in 24 hours, it is called more than 30 milligrams, it is called microalbuminuria, or now it is called albuminuria. The filtering mechanism is defective, and after some time, because of this damage, then kidneys are affected, then kidneys will fail. So it takes some time. In the same way, other organs are also affected at the same time. So we'll have to save these organs. In that way, SGLT2 might help. Right. Next one. Right. Which blood sugar you will control, fasting or PP? This always something comes. When you control postprandial blood sugar, you will have to chase the blood sugar. Please remember. But you can do it in a different way. Control fasting blood sugar first. The blue line is normal blood sugar. On top of it is the yellow one, that is the fasting blood sugar. On top of it is the postprandial blood sugar with each 3 ml. When you remove this yellow line, the curve becomes as shown in the lower panel. Next picture. Next picture. Next, please. Right. If a person has got fasting blood sugar of 220, if you reduce it to 120, the peak value of blood sugar which has gone to 340 has become to 210. Automatically 130 milligrams of postprandial blood sugar comes, the peak blood sugar comes down, and with the continued treatment, it will get stabilized. So reduction of fasting blood sugar must be attempted first rather than control of postprandial when both are high. Next one. Right. We have seen that we eat 3 times and each time blood sugar rises and insulin secretion occurs. So teach the concept of checking blood sugars, at least in the beginning, to convince the client that with each meal blood sugar rises. How to do that? Today you have done for fasting and PP. Within the first week itself, do some pre-lunch and post-lunch one day and pre-dinner. Ask them to do it outside and bring it and show it to you. So you are making the concept enter into his mind that with each meal, he has to control his tongue. And it should be less than 100 and 140, whatever it is. Next slide. Next slide. But one thing you must remember in the diagnosis of diabetes, please look into this yellow picture. When you take food, 2 things may happen. One is the insulin secretion and hormone secretion, other things. How they control. Beta cells are just like that, it is not acting. They're all controlled by various factors. But when you take food, the end product of food, as I said earlier, glucose, amino acids, and fatty acids stimulate insulin secretion. If you do a GTT with glucose, you get a blood sugar to a value of 240 milligram. Or a postprandial blood sugar is 240. Don't treat postprandial blood sugar will be high or less. We'll have to see when it is 240 or so. Now, when you do a meal, do a PP blood sugar with a meal, it comes to 160. How it comes to 160? The glucose-induced hyperglycemia is alone there. Now, fatty acids and amino acids can stimulate insulin, as I said earlier. They brought the blood sugar down to 160 milligrams. So, around 200 to 250, first just wait and see whether it is with glucose or with meal plan or with the real postprandial blood glucose. Next one. Next, please. Right. Proactive management. What is proactive management? The concept is proactive management. Previously, we started with half tablet of sulfonylurea and increased, and after 1 year, 2 years, we have gone to 3 tablets, not acting. Then we added metformin or metformin to sulfonylurea like that. Today, it is not so. The proactive management is within 3 to 6 months, you must bring whatever be the blood sugar level, HbA or the HbA1c level, 10 or things like that. You must reduce it to below 7. In already known diabetic and in newly detected youngsters, it should be 6.5. This by combination of therapy of oral drugs or with the insulin. That is the idea of proactive management. The concept should change. Let us do it one by one. No, combination therapy should be there. Next one. Next one, please. Right. How to convince the patient for control of diabetes? You take 100 rupees note, show 100 rupees note, tell them, ask what it is, 100 rupees. Pre-meal blood sugars, pre-breakfast, pre-lunch, and pre-dinner should be 100 milligram. Post-meal blood sugar, add another 50 rupees, 150 rupees, less than 150, less than 150, or around this 10 to 20% on either side will be okay. Then ask them how many days per week 7 days per week. So HbA1c should be less than 7. Wait. When to also show a 200 rupees note, if it is more than 200, it's a red signal. You will have to control, bring it back to normal. Add a 20 rupees to 50 rupees, it is 70, it shows hypoglycemia. But these two things must be shown. Right, next one. The concept should change, control concept. Next one, please. Right. Why this HbA1c is so important, you have to reduce is, if you reduce 1% of HbA1c from 8 to 7, 21% of death is reduced, 37% of microvascular disease comes down, 14% of heart attack, 43% of peripheral vascular disease, and 12% of strokes gets reduced. That's why HbA1c should be brought down from 8 to 7, things like that, or 9 to 8, 8 to 7, like that, within first 3 to 6 months. Next. Then how can you bring this? You must give a goal chart to each patient. What is that goal chart? Fasting, you enter on the left side, fasting, PP, HbA1c. Likewise, BP, cholesterol, LDL cholesterol, TGL, HDL, things like that. And then estimated GFR, and then weight of the patient, walking or alcohol, like smoking. Write down the patient value in red and the normal value. What is the difference? Suppose if fasting blood sugar is 160, you give him a goal that it should be reduced within 1 week, 2 weeks, or 1 month, like that. HbA1c within 3 months from 9 to 7. BP like that. Same way, cholesterol and all 3 months. And albuminuria, microalbuminuria, if it is there, within 6 months to 2 years. And if he's not walking, 30 minutes of walking today, IDF recommends 60 minutes a day, and no smoking, no alcohol. Next one. Then people are talking today, save the organs, but I have been projecting this over the last 50 years. Do not say urine diabetes is urine sugar, blood sugar, plus protection of eyes, heart, kidneys, and the legs are important in diabetes. It is a metabolic and vascular disease. Next one. Next one, please. So say change the concept of control of blood sugar to plus protection of organs. Next one. Next one, please. Change the concept. If he doesn't follow within 6 months to 1 year, and tell him you will have to prevent the deadly complication of blindness, deadly complication of heart attack, costliest complication, kidney failure, painful complication, amputation, and toothless complication with chronic dental periodontitis. Look at the teeth. Is it shaky? That is the chronic dental periodontitis. And secretive complication, sexual dysfunction. So, diabetes is not only control of blood sugar, it is protection of organs, or he has to prevent them at a later stage. So, attempt from the beginning all these organs. Next. Next, please. Why all these organs are affected? If you are genetically programmed to develop diabetes, you develop hyperinsulinemia first, there is weight gain, and then hypertension, hyperlipidemia occur. For all these things, obesity, hypertension, hyperlipidemia, hyperinsulinemia is the basic cause. And then you get early glucose intolerance, and then the beta cell decline over this side of the diagram. Now, if you look at when there is hyperinsulinemia, in all these conditions, you are having macrovascular disease, and you develop microvascular after the onset of the disease. Then you'll have to tell your client A, B, C, D, E, F. What is this A, B, C, D? A for A1C, B for blood pressure, C for LDL cholesterol, D for desired weight, E for education and exercise, and F for prevention of fatty liver disease. Dr. Pannirselvam is there. He is the author of this. Hold, H-O-L-D, hold. If you shake the hand with others like this, you are holding the hand. Hold spelling is H-O-L-D. Bhavadharani was talking about primordial prevention of future diseases. This hold represents hypertension, obesity, dyslipidemia, and diabetes. Okay, next slide, please. What is there in the belly? Indians have belly first, and within the belly, diabetes, hypertension, obesity, hyperlipidemia, early heart attack, and fatty liver disease are there. Why is it so important? The elephant comes later, but the bell sound is heard to us. The presence of belly is the sign for or a marker for all these diseases that are going to follow. Next one. Right, the heart said, "You dirty fellow, you have spoiled me." How? By overeating, fatty substances, overweight, tobacco use in any form, by stress, taking alcohol, tobacco, and stress, and then this work will not be done without me. The world will go even without you. Uncontrolled diabetes and hypertension, all of them will lead to heart attacks. Plus sleep, you must add. Next one. Next one, please. So diabetes in children is a tsunami. We used to see grandparents, and then now parents, and in future you will see only children. So diabetes is a treasure both in knowledge and wealth. But if you have knowledge only, you can examine the family members, tell them. Next one. Right. This is the picture of family tree. In 1980, we were all 8 children. 1 or 2 developed diabetes above the age of 55. Then 3 children now came, 1 developed diabetes. And the 2 children after 2000, diabetes started coming at the age of 20. There will be 1 or 2 children in the house. If out of 2, 1 develops, it is 50%. If there is only 1 child, even if that is obese, everything comes in that. Be careful. Next one. So why all these things occur? Obesity in children is tsunami like that. DM onset at 20 years of age, more than 20% of obesity occurs. And the Indians, about 40% are obese. Sometime paper cutting it has come. 20 to 40 years, he has to take drugs. And that time he has to be taken care of, or he has to be taken care of by her family. And also you must look for non-alcoholic fatty liver disease. And the person, whether male or female, whatever she earns, she has to spend for the complications. I'm sorry to state that it is a painful thing for me to tell that parents will witness the death of their children in future. Next slide, please. Should we be stuck there? No, don't worry. There are some new developments in the field of diabetes. There is DNA methylation, which will predict who will develop diabetes, who will respond to our treatment, who will go in for complications. So what you should do. Next one. With this, I will stop. Next one, please. If you look at the base, you have adipose tissue where glucose and fat metabolisms are altered, and muscles do not take up, skeletal muscle do not use much glucose. Liver hepatic glucose production is increased, and there is insulin resistance, and then pancreatic beta cell failure, type 2 diabetes occurs. All these things, if it is diabetes is due to genetic disease, the genes are affected by environment, like aging, sex, and then glucotoxicity, increased lack of physical activity, and then stress, pollution, smoking, alcohol, and sleeplessness. Then the subject of epigenetic came. What is epigenetic? Genetics are altered by environmental factor is called epigenetics. This epigenetic changes, that's the red one, may be inherited, that is heritable in this one, or get altered in future, that is stochastic epigenetic changes. So when these changes occur, newer drugs are coming. But what is it? We have purchased the disease from the foreigners by inviting food to our houses, thereby reducing the walking and paying more for the cost of the food also. So we are buying diseases. Please do not tell your patients, do not buy the diseases. Thank you. I think that I will stop here so that we can ask for questions. So I have given you a comprehensive view of what is diabetes, what is insulin secretion, what are diabetic organs, how you must change your concept. Postprandial blood sugar should not be attempted first. It is the fasting to be controlled first, like that. Various concepts I have given you. You can ask questions now.
Doctors, any doubt in diabetes as such?
It is basics. At least have you understood? That is important.
Should not just see the blood sugar value. Behind what all you should think about. Sir has explained clearly. It's not a metabolic disorder. It is metabolic cum vascular disease, affecting all the organs from head to foot.
And if you want, you can get the slides from Dr. Baudarani.
So somebody is asking, in this carbohydrate-rich country, what should be the diet? Please take a...
No, it is
ADA
not the country. That is the environment for you. You will have to take
you
the...
just follow the ADA plate model. Half the plate should be full of greens and vegetables.
Okay.
Only quarter plate, you should take some cereals, and equal to that, try to take pulses, proteins. If you increase the protein, the carb itself becomes lengthy carb. You will not feel more appetite and you will not take more. You can reduce the food, so the weight will not be increasing. And as Sir said, you can reduce your tummy, visceral fat also. It's easy. ADA plate model, half the plate full of greens and vegetables, and quarter cereals and another quarter pulses.
Vegetables are
Sugar-free tablets, you can use it, but limited. Not too much like how they advertised in the medias that can take sugar-free sweets, because all others, carbs and fat is more added.
Yes. Not only that, some of them are carcinogenic as well. You will spend more money for buying these drugs than the cost of the original drugs for diabetes. Reducing the appetite, see, the tongue, control of tongue is the costliest thing. And if you will save money and life and your body.
Somebody is asking about native sugar, all our sugars, whatever it may be.
Yes.
Jaggery or all, that is white sugar, jaggery, palm sugar, honey, dates, date syrups, all are only sugars. You should not take anything. Even sugarcane juice also you cannot take it. And what is that? They are asking many questions.
Okay.
Please let me take up one by one the questions. According to American Diabetes Association, remission in diabetes. See, it all depends on the stage of diabetes. You just follow the blood sugars continuously in early stages. If you are able to bring down under control, both fasting and postprandial glucose, yes, you can even stop the medicines, but keep following regularly. One time it will shoot up, you have to consider the medicines. But as long as you keep your lifestyle under control, definitely you can stop the medicines in early stages, not in late stages where the HbA1c is very high or with complications. And regarding rice, red rice or white rice, any rice, it should not be polished. It should be a raw one. Anything you can unmute and ask. The sessions are over. Visceral fat.
Sir, what do you think about intermittent fasting? Does it help in diabetes? No audio.
Sir, Dr. Sudram, sir.
Intermittent fasting is a concept that is coming now. And the intermittent means 12 hours at least you must give up. You should not take anything or reduce the food, or your calorie must be reduced to 600, and that will reduce the weight, things like that. But what people have understood from Ramadan, most of the people put on weight. They are not able to follow this intermittent fasting. It may help to reduce the weight for some people who strictly follow it, and then they jump upon it, upon the food, and the weight is regained. It is not for all patients.
And again, when you are doing intermittent fasting also, calorie counts. You cannot take in that period more calories and fast for a long time.
Sir, Dr. Sundaram, sir.
Ah.
My humble pranam, Dr. Sundaramurthy, pulmonologist, your student at MMC.
Yes.
Whatever question, the role of stem cell therapy in future possible and oral insulin.
Role of?
Stem cell therapy in diabetes treatment.
என்னமா ரோல் ஆஃப் என்ன கேக்குறாரு?
Stem cell therapy.
Role of stem cell therapy and
oral insulin.
Sir, stem cell therapy now it has become positive in China. They have tried and they have succeeded. And again, Afrisa, very that is in the future. Cipla is going to introduce. We are going to have the launch meet at RSSDA Kochi, November 2025. Afrisa.
Okay.
This has been there for a long time. And then regarding stem cell therapy, you know the cost of it.
Yes, sir. Agreed, sir.
That's all.
Medical insurance பார்த்துப்பாங்க சார்.
சார் மெடிக்கல் இன்சூரன்ஸ் பாக்குறதுன்னா இப்ப நீங்க மெடிக்கல் இன்சூரன்ஸ் எடுத்து ஹாஸ்பிட்டல் போலன்னு அர்த்தம். நாங்கெல்லாம் ஹாஸ்பிட்டல்ல போய் அட்மிட் ஆகி ஒண்ணுமே பே பண்ண முடியாம எல்லாம் வந்திருக்கோம்.
Correct.
So the insurance people cheat public like anything. Promise many things, and people have not understood the terms of insurance, and they suffer a lot. Dr. Sundaramurthy, is it okay for graduates to learn something about diabetes?
கண்டிப்பா சார். அந்த நிமோனிக்ஸ்லாம் பிரமாதம். எக்ஸலென்ட். நிமோனிக்ஸ்லாம் பிரமாதமா சொல்லுது.
Right, thank you.
God bless you, sir. Thank you.
Right.
சாருடைய பேசிக்ஸே வந்து you preserve the beta cells, avoid diabetes or detect diabetes very early at the time of beta cell dysfunction, about retaining your beta cell by 85% or at least 50%. Then subsequently we should not allow the beta cell to deteriorate further. Now the modern methodology, for example, avoiding certain sugar-rich diet, doing some exercise and monitoring, because 20-25 years before we are all student of Dr. Sundaram, during 80s and 90s we didn't have monitoring system. Now we have simply blood sugar monitors are available at cheaper cost. Anybody can do the test at their home and monitor also. By avoiding certain diet, doing some exercise, I could say 5 to 10% of our patients are maintaining the remaining beta cells for a minimum 10 years to maximum 15 years.
Oh, that's great.
Otherwise, we are avoiding diabetes in them. And even if it comes, we are better drugs now along with the metformin, your DPP-4 inhibitor, alpha glucosidase inhibitors, plus or minus pioglitazone, and SGLT inhibitor. They are all non-sulfonylurea molecules which are not stimulating the beta cells, correcting blood sugar by some other mechanisms, maintaining the blood sugar, maintaining the beta cells also. So by
and
which
blood
we
vessels.
are preserving.
Thereby you are saving the blood vessels and organs.
Yes, sir. Once you preserve the beta cell, automatically the insulin secretion will be there, glycemic variability will not be there, or organ damage will not be there. So my microvascular as well as macrovascular complications will not be there. Now, otherwise, we have better molecules, better understanding, better monitoring system. Unfortunately, it is not being applied properly in the community. Such platforms are helping you all because Sundaram is having 45 years of experience. While he was outside or while he was undergraduate, only urine sugar monitoring. While I was undergraduate, also urine sugar monitoring only. Now continuous glucose monitoring, plus glucose, flash glucose monitoring, your SMPG monitoring is there. Only thing we have to educate our patients. Still our patients are ignorant, continuously ignorant. No other way we have to educate, put them in the good metabolic path. At least as he said, better avoid complications, even though we are not in a position to prevent diabetes. But Bhavarani talk, we have to prevent GDM per se. Once you prevent GDM, you are going to prevent type 2 diabetes in the mother, type 2 diabetes in children also. And once you detect early also, we are going to prevent complications. That is the ultimate message Dr. Sundaram and Dr. Bhavarani wants to convey to all of you. So it was a wonderful lecture from both of them, sir. So any subsequent questions also, up to 7 we have time.
இல்ல
Hello,
சார்
sir.
பன்னீர்செல்வம் சார் பன்னீர்செல்வம் சார் ignorant சொன்னீங்கல்ல
Which one, sir?
ignorant சொன்னீங்கல்ல patient
Yes, sir.
அது எதனாலன்னா கூகுள் எல்லாத்தையும் பார்த்துட்டு
இல்ல
இருக்கிற
இப்ப கூகுள் சார் இப்ப சார் கூகுள் இருந்தாலும் our message is we have to highlight or overcome that also, sir. Overcome that also. See, because as you said, many patients are getting confused by Google, including your college process, IAS, IPS, judges, everybody. But it is our responsibility to correct them, put them in the good path. Because as we all know, patients are ignorant in so many aspects, sir.
Sir, Dr. Panneerselvam, can you hear me?
Yes, sir. Okay, I could guess, sir.
Dr. Rangarajan from Coimbatore.
சொல்லுங்க சார்.
Yes, sir. Yes, sir. Very happy, sir.
I know Professor Sundaram for the last 50 years.
Yes, sir. Definitely, sir. You are
Educating...
almost equal senior, sir. Equally senior.
So I know his strategy. I know how he will talk. And one thing which I have to congratulate him, he is a person no one can match him in teaching the fundamentals of diabetes.
Yes,
I have heard
sir.
several lectures in my last 50 years, but yet to see a person who can match with Professor Sundaram in his explanation. So
yes, sir. Definitely, sir. Definitely, sir. We all endorse your view, sir. We all endorse your view, sir. And as you said, if the patient doesn't follow the diet advice, what are all the newer drugs we use? What are all the drugs in pipeline we are going to use? What are all the monitoring system we are going to adapt? Unless otherwise they adopt lifestyle modification, there is no end for diabetics.
Sir, one thing I want to share at this honorable forum, sir. Teaching diabetes, drugs alone is not the panacea. You have to sit and talk with the patient. You give
yes,
a
sir,
patient,
yes, sir. That is important.
And you hear what she says, and you should talk on what she hears. And unless you have this correlation, can never succeed in treating diabetes, sir. There's no hurry, sir.
Yes, sir.
10 minutes I see a patient, 5 minutes I see. No, sir. I take 1 hour to see a patient because I know how Professor Sundaram has been teaching for the last 5 decades. So that is the way the next generation people also should treat the patients with respect.
Yes, sir. So that my message also, sir, simply looking at the number, writing some drug or brand is not the treatment. On what background the number is at higher side is important. So accordingly, we have to manage.
Fantastic talk, sir. Fantastic talk.
Thank you, sir. Thank you, sir.
சார் காசு இல்லாத வைத்தியம் எல்லாரும் நடங்க. நடக்க ஆரம்பிங்க எல்லா டாக்டர்ஸும் ப்ளீஸ்.
இல்ல சார், செலவில்லா சிகிச்சை செலவை குறைக்கும் சிகிச்சைன்னு சொல்லுவீங்க சார்.
செலவில்லா சிகிச்சை செலவை குறைக்கும் சிகிச்சை.
குறைக்கும் சிகிச்சை.
சார் 40 வருஷம் சொன்ன ஸ்டேட்மென்ட் சொல்றீங்க.
உட்கார்ந்துட்டே பண்ணலாமா? ஜமுனாராணி, they can sit and do all the exercise, keep moving all the parts of your body. கை தனியா, hands தனியா.
ஹலோ சார், டாக்டர் விஜய் ஃப்ரம் தர்மபுரி. எனக்கு ஒரு சின்ன டவுட் சார். ஒரு போஸ்ட்மார்ட்டம் பேஷண்ட் வந்தாங்க சார் கிளினிக்கு. அவங்க வந்து இப்போ எனாலாப்ரில் 10 mg எடுத்துட்டு இருக்காங்க மார்னிங் அண்ட் ஈவினிங். அவங்க மெயின் கம்ப்ளைண்ட்ஸ் என்னன்னா, எனக்கு இந்த டேப்லெட் எடுத்தா ரொம்ப ஹெட்டேக் வருதுங்க சார் அப்படின்னு சொல்றாங்க. 53-year-old சைல்டு இருக்கு, சாரி 53-day-old சைல்டு இருக்கு. ஸோ எனாலாப்ரில் ஸ்டாப் பண்ணிட்டு மெட்டோப்ரோலால் அவங்களுக்கு கொடுத்துருக்காங்க கார்டியாலஜிஸ்ட் என்னோட ரெக்கமெண்டேஷனுக்கு அப்புறம். எதனால எனாலாப்ரில் வந்து ஹெட்டேக் கொண்டு வருது மேடம்?
Vasodilatation.
ஓகே. ஸோ அப்போ அந்த கண்டிஷன் இருக்கிற பேஷண்ட்ஸுக்கு அவங்க பல தடவை ஓஜிட்ட போய் கேட்டிருக்கும் போதும் அவங்க வந்து அதே தான் ரெக்கமெண்ட் பண்ணியிருக்காங்க.
இல்ல உங்களுக்கு
It has
சப்போஸ்
to be changed.
நாட் சூட்டிங் அப்படின்னா யூ கேன் ஸ்விட்ச் அவுட் டு அதர்
Yes,
அதர்
it has to be
மாலிக்யூல்ஸ் டாக்டர்.
changed.
ஓகே. ஓகே சார்.
Ultimately,
Thank you, thank
BP should be under control. As she told you, enalapril will cause some vasodilatation for some people.
And the
Okay.
beta
If it is
blockers,
causing
headache
headache, switch out to, switch out to
Hi,
other
sir. Good evening, sir. Myself, Dr. Maniratnam from Chennai. Sir, can you please confirm the recommended dose of dapagliflozin per day for a patient? Because I can see some prescriptions with dapagliflozin prescribed as a BD dose and all. But as per my understanding, it should be a maximum of 10 mg per day. What is your comments about that, sir?
Maximum 10.
Minimum 5 milligram to maximum 10 milligram body dose, doctor.
Okay, sir.
Once daily.
Secondly, okay,
Sir,
sir.
டாக்டர் அதான் வந்து டாக்டர் இவரு பன்னீர்செல்வம் சொன்னாரு, ப்ளீஸ் நோ அபவுட் த ட்ரக்ஸ், ஹவு மச் இட் கேன் பி யூஸ்ட், விச் டு பி யூஸ்ட், அந்த மாதிரி தெரியாம நிறைய பேர் போட்டுறாங்கன்னு தான் he was worried.
ஆமா. ஏன்னா
Sir.
உங்களுக்கு pharmacokinetics and pharmacodynamics of various combinations, unfortunately, many doctors are not knowing it. And pathophysiology behind hyperglycemia also, many of them are not knowing. So simply they look at the number, they write the drug. Especially this non-diet about it, as Dr. Sundaram pointed out, simple diet alone is sometimes raising the blood sugar. By avoiding those diet, the blood sugar is coming down. So by looking at that, immediately writing some drug is, so that only you have to analyze on where, suppose beta cells are totally failed, the fasting blood sugar as well as postprandial blood sugar, both will get high, increased. Such cases, they require insulin only. You cannot treat them with drugs or sulfonylurea or any other drugs. So that your question is dapagliflozin OD only, but now many companies are marketing triple drugs, metformin, dapagliflozin and gliptins, metformin, dapagliflozin and sulfonylurea. And triple combination is many companies with various combination, various trade names they are marketing. You should not get confused.
ஆன்டி-ஹைப்பர்டென்சிவும் அது ஆன்டி-டயபெட்டிக்குமே கம்பைன் பண்ணிட்டாங்களே.
ஆமா, அது வேற கம்பைன் பண்றாங்க இப்ப. For example, dapagliflozin and bisoprolol they are combining. Dapagliflozin, pioglitazone also they have combined. So that while you are using anti-diabetic or anti-hypertensive, suppose you are not familiar, no harm in referring them. So our message, I have told you initially also, our aim is good control of BP, good control of diabetes. Or if possible, prevent diabetes or detect diabetes very early, maintain the good control. At least future diabetics should avoid complications. So like leprosy. Leprosy we have not treated properly 30-40 years before. So that many had crippling complications. Without vaccine, we have tackled leprosy. So we have identified early, treated effectively, no crippling complications now. Similarly, even though polio we have eradicated by polio drops, but 30-40 years before we have not covered all the children. We have revised our thoughts from primary health center, sub-center to Anganwadi, then bus stand, aerodrome.
The same way like how we eradicated
the camp,
communicable
catch the less than 500, the 5 years with the phone number. We took 20 years effort to eradicate polio. Now for past 10 or 15 years, polio-free India. Similarly, we have not taken any positive step or effort for diabetes. Unfortunately, we allow the disease not only all over world. In India, it is fastly growing, especially in younger population. If they are not under control, they enter into complications. Once they enter into complications, the productive life, earning, everything will get spoiled by this disease. So that only we...
Anil sir, like how you have vaccines for the communicable diseases and you have eradicated, now we have come out with the preventable measures. That is, seeing at 8 weeks and putting them on metformin, we are able to prevent the hyperinsulinemia and all the effects what Sundaram sir said.
Sir, thank you, sir.
Excuse me, sir. 1 minute, sir. Sir, SGL2 in female போட்டோம்னா urinary infection வருங்களா சார்? Is it not advisable to give SGL2 in females?
Minimum or 5 to 10% will have UTI. Not for all. Or 5 to 10% will have UTI, baronopastitis, vulvovaginitis. If it is recurrently coming, better to avoid the molecule. Whether it is DAPA, EMPA, or CANA.
You must tell the
DPP plus metformin போட்டுக்கலாம்.
Paneer, they must drink with 300 ml of water more.
More
with,
water has to be taken.
Yes. And then they must be instructed about this urinary tract infection.
Infections.
Without that, please
genital
don't
hygiene
prescribe.
சொல்லணும்.
Tell them male or female. I have heard a patient developing you see, patient may develop anything. Gangrene of the scrotum with SGLT2.
Melanogastritis, Funes gangrene.
People see, if you go in the wrong path, you may meet with the accidents. But if you do it properly, definitely drive properly, follow the rules, definitely. So
Definitely, you have to
know the
avoid
side effects.
dehydration, advise them adequate hydration, and genital hygiene is very important.
Despite that, if they have, better avoid.
Yes. Know the side effects, know the contraindications, know the indications of any drug for that matter will help the patient, will help you and get you good name.
Okay, sir. Thank you, sir.
Analog is only one doubt, sir. Analog is better or normal part in the big start அதே போதுங்களா சார்? Analog is only இதுங்களா சார்?
ஸ்டாரோட பேஷண்டோட எக்கனாமிக்கல் கண்டிஷன் எது சஸ்டைனபிளா இருக்குன்னு பாத்துக்குங்க. ஒன்லி திங் அனலாக்ஸ்னா இட் ஹாஸ் டு பி கிவன் 10 minutes பிஃபோர். இது வந்து half an hour ஸ்ட்ரிக்டா சொல்லி இன்ஜெக்ஷன் சைட் எல்லாம் நல்லா சூப்பர்வைஸ் பண்ணி கொடுத்தீங்கன்னா தாராளமா you can give the human mixed and other things. Analogs are very costly. If they can afford and sustain, that is more important. அது பார்த்துட்டு you prescribe.
Analog 10 minutes before food.
Analogs வந்து little before, அதாவது 10 minutes 15 minutes தான். Whereas if you take actrapid, lentard, mixed அதெல்லாம் human insulins எல்லாம் எடுத்தீங்கன்னா it has to be 20 to 30 minutes.
20 to 30 minutes. Thank you. The sugar, the சக்கரவள்ளி கிழங்கு சாப்பிடலாமா? எல்லாத்துலயும் இப்ப வர சக்கரவள்ளி.
Wrong information. யார் சொன்னாலும் நீங்க wrong. They are all rich in starch. Totally wrong. If they are non-diabetic, they can take it. அதே உங்களுக்கு பூமி கீழே விளையதுல சோப்பு முள்ளங்கி, வெள்ளை முள்ளங்கி, ஒயிட் ரேடிஷ், ரெட் ரேடிஷ்ல ஸ்டார்ச் கிடையாது, வெஜிடபிள்ஸ்ல ஸ்டார்ச் கிடையாது, கிரீன்ஸ்ல ஸ்டார்ச் கிடையாது. பட் உருளைக்கிழங்கு, வள்ளிக்கிழங்கு, சேனக்கிழங்கு எல்லாம் they are all rich in starch. ஸ்டார்ச் கண்டென்ட் எப்படின்னு கேட்டீங்கன்னா, ரைஸ்ல இருக்கிற ஸ்டார்ச் வந்து உங்களுக்கு 50 மில்லிகிராம் தான் சுகரை ஏற்றும். தெனை, சாமை, வரகு, குதிரைவாளி எல்லாம் 30 மில்லிகிராம் தான், ஏன்னா ஃபைபர் கூடுதலா இருக்கிறதால. கேழ்வரகு, கோதுமெல்லாம் ஒரு 40 தான் ஏற்றும். பட் வள்ளிக்கிழங்கு, சக்கரவள்ளி கிழங்கு, சேனக்கிழங்கு, உருளைக்கிழங்குலாம் மினிமம் 100ல இருந்து மேக்ஸிமம் 150 வரைக்கும் ஏற்றும். அதெல்லாம் டோட்டலி அன்சைன்டிபிக் ராங் இன்ஃபர்மேஷன். Non-diabetic can take, but diabetic should not take. They take blood sugar will never get controlled by whatever means whoever treats.
Non-diabetic ரெகுலரா நிறைய எடுத்தாங்கன்னா வெயிட் போடும்.
அதனால யாருன்னா சொன்னாங்கன்னா என் நேம சொல்லியே கோட் பண்ணுங்க, திட்டுங்கன்னு சொல்லியிருக்கேன் நான் என் பேஷண்ட் கிட்ட. என் போன் நம்பரை கொடுத்து என்கிட்ட பேசுங்கன்னு சொல்லிடுறது நான்.
தேங்க்யூ சார்.
Totally unscientific people are talking about this. Including educated people are getting confused.
Sir, walking, physical activity, எவ்வளவு நேரம் சார்? 30 minutes, அங்க சில பேர் 45 or 1 hour.
உங்களுக்கு தெரிஞ்சதானே ஒரு half an hour to 1 hour simple walking.
half an hour 1 hour வந்து ஒரு நேரம் பண்ணிட்டு மீதி நாள் சும்மா எல்லாம் செடன்ட்ரியா இருக்க கூடாது. இட் இஸ் இன்டர்மிட்டன்ட். அதாவது sit not more than 1 hour உட்கார கூடாது ஒரு இடத்துல. ஓல்ட் ஏஜா இருந்தாலும் they have to break the இது sitting by at least walking for ஒரு 2-3 minutes walk பண்ணிட்டு அப்புறம் உட்காரலாம். ஏன்னா கண்டினியூஸா இப்போ ஓல்ட் ஏஜ் எல்லாம் படுத்துக்கிட்டு டிவி பாக்குறது, உட்காந்துக்கிட்டு டிவி பாக்குறது, காலையில கேட்டா half an hour நடந்துட்டேன்னு நாள் பூரா சொல்றது நோ.
Correct.
Sir, I have one more doubt, sir. Recently I came across the patient's prescription. Hello? Sir, recently I came across a patient's prescription. Actually, he's a 55-year-old patient with a history of 4 years of type 2 DM. He was being treated with glycomet, sir, initially. Now his HbA1c is 7.6 in this admission. He has admitted for complaints of bilateral lower limb swelling, and eventually he was diagnosed with NAFLD related CLD, sir. But the diabetic medications was changed to glycomet GP1. But when I asked the consultant regarding this usage of sulfonylurea in a liver disease patient, I was given an explanation that it is not recommended only in severe liver disease patient, but it can be given in mild to moderate liver disease patient. But I don't know whether it is appropriate because
seeing HbA1c they would have done. But as Paneer sir said, we have better combinations. Before going to sulfonylurea, you can try the other combinations.
இல்ல மேம் அவங்க
for
வந்து
this patient,
சல்பனிலுரியா போடலாம்னு சொல்றாங்க. அதுதான் என்னோட
இல்ல டாக்டர் இல்ல SGLT inhibitor along with metformin is the ideal combination.
ஓகே எஸ் சார் ஐ அண்டர்ஸ்டாண்ட். அவங்க என்கிட்ட அப்படி டிஃபெண்ட் பண்ணாங்க, இல்ல நம்ம போடலாம், மைல்ட் டு மாடரேட்
இல்ல
டிசீஸ்ல
அது
போடலாம்.
இன்னமும் சல்ஃபனிலுரியாவில இருந்து நிறைய பேர் வெளியே வரல. பட் சல்ஃபனிலுரியா டு பி யூஸ்டு வெரி ரேர்லி, வெரி மினிமம்லி. பட் சல்ஃபனிலுரியாவுக்கு இண்டிகேஷன் வந்து வர வர குறைஞ்சிருச்சு இப்போ உங்களுக்கு. ஏன்னா அலாங் வித் சல்ஃபனிலுரியா we had metformin 20 years before. Now along with the metformin we have a lot of options, especially for this particular patient. Instead of sulfonylurea, better to combine SGLT inhibitor that will remove the liver fat also, reduce the weight also. That is ideal combination.
Thank you, sir. Sir, and one more doubt, sir. Not doubt, actually. I would like to hear from you regarding the use of semaglutide in Indian population, sir. Because as I know, it is not easily available here. Ozempic is not available here. Whereas my friends in Norway and such countries, they are telling they are getting very much benefits from the use of semaglutide. So, what is your comment on that?
டாக்டர் Wegovy வந்துருச்சே, இங்க இருக்குதே.
Injectable form வந்துருச்சுங்களா மேடம்? Tablet form
எல்லாம் very much available.
இல்ல இன்ஜெக்டபிள் ஃபார்ம் வந்துருச்சு டாக்டர். பட் நம்ம கண்ட்ரில வந்து ஒபிசிட்டி பாப்புலேஷன் அந்த அளவுக்கு இல்ல, அஃபோர்டபிலிட்டியும் இல்ல. அதனால we can use this drug. Affordable obese people you can use.
Okay.
And each dose cost about 4,000 rupees per week. இப்போ 4,000
single dose. அதாவது ஒரு மாசத்துக்கு 16,000 ரூபாய். 4 இன்ஜெக்ஷன் 16,000 ரூபாய்.
obese people you can use.
அதாவது once they stop, they should follow lifestyle, otherwise they'll regain weight.
Okay, madam. Thank you.
Sir, Panir sir.
I think 7-10.
Panir sir, whatever last way, my suggestion, sir. You tell all your patients not to go for Swiggy. இந்த மாதிரி ஸ்விக்கியில போய் வாங்கி சாப்பிடுறீங்க. all the healthy people, the young boys and girls are overweight because of Swiggy.
பசங்களா ஸ்விக்கி தான் சாப்பிடுறாங்க.
அதுதான் நம்ம முதல்ல டார்கெட் பண்ணணும் சார்.
வீட்ல எல்லாம் ஒர்க்கிங் கிளாஸ்ன்றாங்க, சமைக்கலன்றாங்க, சமைக்க தெரியாதுன்றாங்க இப்பத்திய கேர்ள்ஸுங்க.
சமைக்கிறது இல்ல, புருஷனும் கை நிறைய சம்பாதிக்க, பொண்டாடி கை நிறைய சம்பாதிக்கிறீங்க, வீட்டுல சமைக்கிறதே கிடையாது சார்.
ஆமா. இப்ப
ரங்கராஜன் சார் ஒரே ஒரு ஐடியா கொடுக்கலாம். போங்க ஸ்விக்கி சொமேட்டோ இல்லாம நீங்களே நடந்து போய் சாப்பிட்டு நடந்து வாங்கன்னு சொல்லுங்க.
ஆமா, அது வேணா பண்ணலாம். Hello? Hello?
Yes.
We can close the meeting, I think.
Yes, sir. Yes, sir. Yes,
now
sir.
7:10. Sendil sir, thank you very much for your great opportunity.
Yes, sir.
To share our views through College of General Practitioners of IMA, and about more than 1,000 people joined. My profuse thanks to my speakers, Dr. Muruganathan sir. He is very well known to everybody. And Dr. Bhavadharani very well highlighted about the primordial prevention and its importance. And our teacher, Dr. Sundaram, has very well highlighted about the basics. So basics we should not forget. So like anatomy, physiology cannot be forgotten. So unless otherwise we know the basics in strong, we cannot apply the modern things also. In that way, we have to profusely thank our professor also. And all the participants who actively participated and clarified their doubts. Once for all, I thank every one of you, especially Dr. Bhavadharani, to create
don't
this.
say 1B alone, blood sugar. As sir said, think blood sugar means 3B. 3B.
Yeah. To start with beta cell, then blood sugar, then
blood sugar, beta cells and blood vessels.
No. Protect the beta cell by which you can protect others. Right. Thank you.
சுந்தரன் சார் அன்மியூட் பண்ணி நீங்க ஏதாவது சொல்லுமாங்க சார்? சார் அன்மியூட் பண்ணல. பன்னீர் சார் உங்க வாய்ஸ் கேட்கவே இல்ல, சுத்தமா கேட்கல.
இல்லம்மா, ஹோஸ்ட் வந்து அன்மியூட் பண்றாங்க. இட்ஸ் ஆல் ரைட்.
Not audible, sir. Yes, sir.
Okay. Whatever you have learned, try to apply yourself first.
Sendil sir.
Almost all of us have families.
Sir, yes, sir.
We are all born with brothers and sisters. Now there is only one person, either a male or female. That's all. No relationships. So both of them are earning, dumping money to the child and spoiling the future of the children. So this attitude must change. So unless the parents change, children are likely to develop disease, and they will have to spend more and more. That's what I said. 20 years to 30 years, parents have to spend. After that, whatever he earns, he has to spend for that. All starts with your Swiggy and homemade foods, outside made foods, not homemade foods. You make in your home, change your culture, go back to your normal culture, then diseases will disappear, which is not possible. It should be made possible individually.
My humble request is to year after it should be fit to conceive. If at all they have conceived, please do a 2-hour postprandial at 8th week and see if it is 110 to 119. We have to put them on metformin 500 half BD.
Correct
Thank you.
message.
Thank you. Thank you. Thank you.
Yes, madam. Thank you, madam. Thank you, sir.
Thank you. Thank you. Sir, we can finish?
Yes, madam. We can wind up,
Yes, sir.
madam.
Thank you, sir. Thank you, sir.
Thank you, madam. Thank you, madam. Yes.
Dr. Sendil, wonderful, excellent.
Yeah,
Thanks
Thank you,
for the
madam. Thank you so much,
opportunity
sir.
for all of
Panneesaran,
us.
sir.
All
Thank you,
great.
sir.
Thank
You
you.
had
Thank you.
a very good session, and even Muruganathan sir just called, sir, and he was telling it was a very wonderful session, and it was nice to meet up with diabetes colleagues.
Yes,
Yes,
sir.
sir. Sure. Fine, madam. Thank you, madam. Thank you. Right. Thank you.